Professor Ramzi Khamis. I'm a professor of cardiology at National Heart and Lung Institute, Imperial College, and consultant cardiologist. And on behalf of myself and the core director of the Vascular network at Imperial, Professor Anna Randi, who's just over there, I'd like to welcome you all to the new series of the Vascular network talks and events. And we're kicking off with a very important topic, which is women's cardiovascular health and disease. I hope you enjoy the afternoon. We've got, just for awareness, people online on YouTube, and there might be some questions coming in, so we could field them on YouTube as well. And please feel free to ask questions in the question time. So I'll start by really framing the question. I titled the introduction, The Unfinished Scientific and Clinical Agenda, because I think just an afternoon doesn't really give it its kind of, the needed time to discuss all of this. But the issue is not just in the kind of basic translational science field. The problem is from epidemiology to mechanisms to diagnostics and systems design. It's not a niche topic. CVD is the leading cause of mortality in women. There's a scientific deficit in figuring out the exposure, the phenotype, the diagnostic thresholds and endpoint capturing in women in particular. And it's not a communications problem. The recurring pattern is under recognition, under treatment, under representation. And really, kind of, the thinking is that it's same biology filtered through less sensitive clinical system. And it's not a single disease. Women's CVD spans obstructive CAD, plaque erosion, ANOCA, MINOCA, SCAD, HFpEF, cardiomyopathies, and so on and so forth. And so really the thesis for today is to try and move from women as a subgroup to sex-informed disease taxonomy, diagnostics, trials, and services. And the epidemiological signal is quite big. The clinical response remains imprecise. 19.8 million CVD deaths in 2022, and we think 35% of deaths in women is attributed to CVD. And more recent data from the European Society of Cardiology consensus paper just last week said 30% of female global mortality. And the crude mortality data really conceals a lot of things. For example, risk accumulation across the life course and modifications that are specific for women. Pregnancy, menopause, autoimmune disease is more prevalent in women than men. Cancer therapy, in particular breast cancer, deprivation, ethnicity, and gendered health system access. Why does it matter to us in the vascular network? Well, atherosclerosis is not later life obstructive CAD. There is endothelial pathology from very early on, inflammation, thrombosis, plaque erosion, vasomotion, microvascular disease dominating many female phenotypes. And we'll hear more from our keynote speaker, Aloke Finn, on this. And so there is an avoidable gap that needs addressing. And we think, well, I think that there should be a life course risk architecture in particular for female cardiovascular phenotyping, as it is not really captured by age, LDL-C, blood pressure, diabetes, and smoking alone. And you're talking about in the reproductive years, you see hypertensive disorders of pregnancy, gestational diabetes, preterm delivery. In the postpartum, you see a stress test with lifelong surveillance after adverse pregnancy outcomes needed. You see menopause transition with endothelial metabolic adiposity shifts and premature menopause as risk enhancers. And obviously, there's the inflammation autoimmunity, which is kind of a special interest for me in the cardioimmune clinic, where you see many more women with SLE and rheumatoid arthritis and chronic inflammatory diseases having accelerated vascular risk. And then there's the cancer survivorship. Of course, men also have cancer, but breast cancer in particular and breast cancer therapy adds the cardio oncology overlap to the question, which is something that also needs to be thought of. So in terms of diagnostic inequity, misclassification begins before the cath lab, symptoms, troponin thresholds, pathway activation. And really, a scientifically precise approach would require abandoning the atypical framing and using assay-specific sex-aware interpretation of when you see patients. And so, generations of doctors described symptoms as atypical. And we think that chest pain remains the most common ACS symptom in both sexes. Women more often report associated dyspnea, nausea, fatigue, but really they're not really atypical. They're just slightly variable. And the biomarkers thresholds matter. Professor Meyert presented a lot of work on that, on the troponin assess and prediction in populations. It's really important to know that women have a lower centile upper limits of normal, and the thresholds can under-recognize myocardial injury in women. And within the definitions, mechanisms do matter. So women have more non-obstructive and non-atherosclerotic mimics and overlaps. And so the diagnostic endpoint should not be no obstructive coronary artery disease, as it had been for many years in the cath lab, but it's the mechanistic attribution. Is there plaque rupture, erosion, spasm, embolus, myocarditis, like a SUBO-SCAD, or vasomotor disorder. And so coming on to plaque, really, it's not kind of about size, and hair plaque is not simply smaller than his plaque. And acute coronary mechanisms are really important here, and they're becoming more easy to look at with optical coherence tomography intravascularly and modern CT coronary angiography, looking at plaque erosion in particular. And I think Aloke will talk a little bit about that, and CT plaque phenotyping. And then there is the emerging human plaque work looking at sex-linked extracellular matrix remodeling and TGF-beta associated biology in fibrous plaques. And so rupture, erosion, spasm, vasomotor, and SCAD are all different pathologies that fall under the kind of same category. We have Professor Rasha Alami, who will talk to us about angina in women. And Inoka CMD is common, morbid, mechanistically testable, and a normal coronary angiogram has historically ended investigations precisely at the point where diagnosis should actually begin. And now we have other ways of making the diagnoses with invasive physiology, CMR, PET perfusion, CT plaque metrics, endothelial pathology, biology coverage. And in myocardial infarction without obstructive coronary artery disease and spontaneous coronary artery section, really, it's Minoka should be a working diagnosis, and SCAD is sentinel, female predominant ACS phenotype. And at Imperial, we have a dedicated SCAD clinic that looks into that. And really, the goal should not be just to reassure, but to assign mechanistic causes for the presentation and protect the patient from the wrong intervention. Even with angioplasty, sometimes it could be the wrong intervention. So this afternoon's SCAD and genetics discussion can be framed as a model for the whole field. Phenotype first, mechanism second, system pathways third. Just in terms of service models as translational infrastructures, this paper came out last week in the European Heart Journal. And this is Julia Grabsa, who was an SHO with us and a fellow as well, and spent many years at the Hammersmith. And she's now the director for education in ECHO at Brigham and Women's at Harvard. And obviously, we're very proud that Julia is a member of faculty there. And she's written this paper, which is the clinical consensus statement of the 4 European heart associations. And really, it's talking about women's heart centers. It's a new idea. Some people think it's a good idea. Some people think it's controversial. It'll be interesting to hear the views throughout the day. But really, it's kind of well laid out in this paper that I encourage people to read, and it's available online. So today we have quite a a varied program that covers quite a lot of the issues, but is obviously not comprehensive. And we think that women's cardiovascular science is a test case for precision cardiovascular medicine because biology, diagnostics, therapeutics, and systems must all be made explicit. So I'll stop there for a minute, and I think we have hopefully Professor Cassidy joining. I can't see her there or online. No, so she's probably held back. So I think the next speaker is Aloke Finn, but we don't want to start too early because otherwise some people will miss it. So what I'll do is I'll just open to the floor and kind of, even before we start the session, see what people, there's Barbara. Hello, nice to see you. So we can open afterwards. So Professor Cassidy, you're needed here. Yeah, yeah. So it's a pleasure to introduce Professor Barbara Cassidy, who is the head of the National Heart and Lung Institute. A lot of people know Barbara from having been the president of the European Society of Cardiology, and she's now the chief editor of JAMA Cardiology and about 10 other jobs. So we're really grateful that Barbara made the time made the time to be with us. And Barbara, you've seen my slides, so
yes, I thought I'd maybe say something and without the slides so that we keep it short.
Okay. Yeah.
I think they probably can hear me.
Oh, it's just
for the YouTube.
The internet.
Yeah.
Okay.
So,
Right.
Yeah.
Is that all right?
It's about good, yeah.
Yeah. Well, thank you very much. What I really wanted to do is something not quite scientific, but something that I think that when we are getting into this issue of sex differences and things, one needs to keep in mind. My generation has spent most of their career trying to convince the community that women are like men, right? And men are like women, and there is no difference. That has been, if you like, the focus of my activism in this sense, for in this area for many years. It is to me quite concerning to see now that women have established a bit more visibility, to see them to some extent repeat the issues that used to be a point of contention when I was younger. So, people thought that if you were, it was fine to have a panel of people that they were all men, for the so-called manels, for example, or that, it was inconceivable that a female surgeon could be good at doing a prostatectomy, All of this is now over, to some extent, except that we are seeing them, to some extent, the mirror image of that. Female-only panel, female medical center, where is that written? That are almost entirely populated by female doctors in the United States. There are the data there if you want to find them. And to me, that is regressive. And so I am really hoping that people who are interested in this area would keep this at the forefront of their mind. There is such a thing as a bandwagon, and that is something that, again, we need to be careful. All of this statement, women die of cardiovascular disease more often than men. The question is when, right? What are we going to do? We want to prevent premature death. We don't have any aspiration to prolong our lifespan. And so if a woman in the 90s has a heart failure as the diagnosis, we know, one, that the diagnosis at that age is not quite so accurate. And two, that there isn't a lot at that point that we can do about it. So if you look at premature death, the premature death for cardiovascular disease as death by the age of 70, from 35 to 70, is still more common in men. The other thing that people say, and is the second point, is that women are not included in clinical trials. And that has that connotation that somehow the environment is doing this on purpose, right? The reality is that women are much less likely to respond to an invitation, to adhere, to agree to be randomized, to agree to adhere to the treatment in the clinical trials, whether that is a placebo or an active treatment. So it's not a matter of having more side effects. And in some respect, we have not been successful really in communicating cardiovascular risk to women in a way that would engage them in being part of a clinical trials. So people are really quite, they're trying to recruit women, but in a trial, if you lose patients post-randomization, is a tragedy. It's something that can seriously affect the power of your trial and therefore your ability to get a result. And when this has been investigated very superficially, the response has been that women felt they had more to lose than to gain in being in a trial of, let's say, primary or secondary prevention of cardiovascular disease. So there are ways that, for instance, a study that I would like to do is to randomize the type of consent to the participants in actually showing the risk not as probability of having a cardiovascular event in 10 years, but how many years you lose if you carry on like that. What is the impact on healthy life? To have it more material than a percentage that may or may not really hit. The last thing that I want to say that one has to be aware are the unwanted consequences of good intention. And again, we want to focus on, find the differences, what issues there are between, men, what biological difference that can maybe drive treatment or that can alert the diagnosis. And that is important because women are still underdiagnosed and undertreated by a number of metrics. But the stress on differences has been sometimes harmful. For example, because you have a lower number of women in clinical trials, you do a meta-analysis, you see that, for instance, statins cause a same point reduction in the cardiovascular risk. But because there aren't many women, the confidence interval touches the zero. And this has been used by female editor of journals and others to say that women should not be treated with statins because the effect is not certain and it has not been absolutely proven. So this is an extremely dangerous attitude because once the effect of preventative measures has demonstrated, you almost have to change your statistics and demonstrate that it doesn't work in women, right? It is the prior changes and the whole view of that changes. So until, if you have a intervention that works, you have to assume that it would work in both sexes, even if it's not, particularly if the point estimate is the same, even if it's not statistically significant. So, you know, all welcome research, welcome the focus on women, and welcome, you know, the reason why women are undertreated and why they don't perceive that they are at risk, but beware of not, you know, being in the position of really causing this misunderstanding that at the end are completely counterproductive to what you want to achieve. That's what I wanted to say.
Thank you.
You're
Ms.
welcome.
Cassidy. So this kind of gives us a really nice introduction for the day, and hopefully we'll have a lot to talk about. So we have just 5 minutes. I think one of the really interesting things you said is about women health centers in America and how it's kind of, you know, siloing the problem within that. And I think the paper from European Heart Journal kind of talks about keeping the care in the usual way and having these extra centers that focus on maybe gathering data, focusing and looking at the extra factors that are special for women. I think, you know, you're right, because, you know, you can't kind of, you know, I think you have to discriminate positively in a way that, you know, the shared disease processes and the shared treatments should be given. But there is a few extra things that need to be looked at, and this is what we're focusing on this afternoon.
Sure, but you know, I mean, you can't have your cake and eat it, right?
Yeah.
So if you say that 51% of people are women, and so women are not a minority, that means that every medical student needs to know, you know, that some diseases or something are more common in women, and this should be common knowledge, not in a small center that, you know.
I agree. Yeah, so I think that's good. Anyone wants to kind of pitch in before we start with the first talk? Jamil?
Yeah. I agree with Barbara. I think it's dangerous, is maybe too strong a word, but I think it's the wrong way to go to have specialist centres. I think in the past we've had basically male-driven departments which are run effectively for men. And it's not surprisingly that men go into studies because they're kind of men consent patients. I think we need to ensure that our departments recruit women. We've got women leads across our departments.
Exactly.
It's great to have Barbara here, but when I went to the British Cardiac Society last week and I look at departments, we're underrepresented. We look outside London, very few women in senior positions within our departments. Very few ethnic minorities. Actually, you know, we're an exception in Northwest London. What we need to do is to normalise, so our departments have got women, then women are then, well, the culture will be different. I suspect patients, there might still be an equity in patient recruitment, but it'll be more even. But I think it's really important that we try to get our faculties right. And I do think that our grant-giving bodies do need, if there's discrimination, it should be positive discrimination from there, because I think the way it's going is a dangerous. I can see it's born out of frustration because we're not changing, and so groups of women are getting together to try to force change in a different way. But I think we need to be very clear in our departments that we need to make sure that we give every opportunity to bring more women into the system. And have I got time for one more point, just around common disease? So I think just around common disease, I think this field is littered by woolly thinking around coronary disease. So we've accepted that patients with tight coronary stenosis who have chest pain, the chest pain is because of that coronary disease. Of course, there's an overlap between coronary artery disease and angina, but angina is a clinical diagnosis. And I think we've often in the past accepted lots of strange pains in the chest are due to angina because we haven't thought about things properly. So I think, I'm sure Rasha will address this because she's doing some really nice work in her lab. But it's really important with chest pain that we're really clear what our definition of angina is, because there is no real gold standard. It's like, think of it like heart failure. It should be a clinical diagnosis, but we need to anchor that first. and then think about kind of coronary disease and possibly microvascular disease. But I think the past history of this is really littered by woolly thinking. So going forward, I hope my younger colleagues will be much clearer than my generation in dealing with this.
So as you can see, there's a lot of really good points there, and some also quite strong feelings about not just policy, but also pathophysiology, disease presentation. So this is great. So I think it kind of really sets the scene, and it's with pleasure that I welcome our first speaker, our keynote speaker, Aloke Finn from the University of Maryland, who Aloke is a great friend and collaborator. He's in Maryland at the moment. We're very grateful to him for joining online. And he's going to talk to us from CV Path on the pathology of genetic variants in spontaneous coronary artery dissection. Aloke, the floor is yours.
Hold on one second. Hold on. Can you hear me?
It's great.
Yes, we can.
Hello? You can hear me? Okay, good. I wanted to make sure. Sorry. Can you see my slides?
Yes, really good. Well done.
Perfect. All right, Ramsey, thank you so much for the really nice introduction. I'm sorry I can't be there in person. I think the comments that were just said prior are very interesting and stimulating thought for discussion. I'm going to talk about a specific disease we know is an important disease. I don't know if this, are you seeing everything okay in my slides?
Not now.
Hold on, something just happened. Let me just see if I can share again here. Hold on one second. How about now? Can you see it?
Yeah.
Okay, is that okay? So I just want to mention this is work done by one of our fellows, Takamasa Takanaka, and we did this in collaboration with some of the geneticists at University of Maryland. So I want to highlight them in terms of the involvement they had. What is spontaneous coronary dissection? For those of you who aren't familiar, spontaneous coronary dissection is characterized by structural disruption or tear within the layers of the coronary artery wall, where accumulation of blood within the dissected layers compresses the lumen, essentially resulting in myocardial ischemia or infarction. It's not atherosclerosis per se. This is a very different disease pathogenesis. I'm going to explore that. The diagnosis of SCAD, and I'll call spontaneous coronary dissection SCAD from now on, is most often made during coronary angiography. And in recent decades, I think Ramsey mentioned the use of OCT or IVUS, intravascular imaging techniques, has facilitated increased recognition of the disease, whereas we didn't have it previously. And this is, I always bring things home to a case presentation because I think it helps to humanize some of the things we're talking about. This was a 39-year-old woman I treated a number of years ago. She came in with history of hypertension, high lipids, and presented with chest pain. EKG findings demonstrated non-specific conduction delay and anterior Q wave suggesting an ongoing infarct, myocardial infarction. And laboratory findings were troponin I was elevated, consistent with the myocardial infarction. So she was transferred to our hospital, and we performed a cardiac catheterization, revealing a left main coronary artery dissection extending into the LAD with mid-LAD occlusion. And we performed PCI and stenting of the mid-LAD. We were able to reestablish flow in the left anterior descending artery, and her chest pain actually got better. And we performed an OCT just to look at the extent of dissection. Now, there was some residual dissection left in the left main and proximal mid-LAD, but there was good flow in the vessel. Conservative management of SCAD was pursued with subsequent transfer to the ICU. However, hours after the intervention, she suffered VT and VF arrest requiring ACLS, and unfortunately passed away despite prolonged CPR and defibrillation. And we ended up getting an autopsy in this particular case because we really wanted to understand what had gone wrong. And it showed evidence of hemorrhagic reperfusion involving the LAD territory. Microscopic pathology showed this dissection, as you can imagine, and the stent was patent on gross examination. So this was the actual case. I'm going to highlight the angiogram briefly. You can see in the panel A, the LAD is shown on the left-hand side. I don't know if you can see my pointer, but you can see this LAD kind of peters off to nothing. And after the fix, after the stenting, we, of course, had gotten patency in the LAD and had good flow. And you can see here on the lower panel C, E and D are OCT images of the left main coronary artery and proximal LAD. And what you see in the OCT is you see a patent lumen. Really, there's very little atherosclerosis, but you see underlying that, you see a slit in the vessel wall. And I don't know if you can see that, but that's consistent with sudden coronary artery dissection. And that's best seen in the arrow on the longitudinal view of the OCT, just highlighting that there's an area of basically a void in the arterial wall where there's probably blood sitting there. We can't tell that on OCT, but you can see clearly. And then, of course, the heart was subjected to autopsy and gross dissection. You can see the massive amount of hemorrhagic reperfusion there was in the LAD territory. And of course, this is another case we had gotten recently where you can see a slit-like line in the left main here. This is a young lady had presented, and you see the LAD fill slowly. So I just want to remind you, these cases come quite not infrequently, and it's very difficult to understand what to do with them because even the interventional teaching for how to treat these situations is not quite totally clear, and it's a very difficult disease to treat. Now, what is the epidemiology of SCAD? These are young people for the most part, 45 to 55 years of age. It's responsible for 1 to 4% of all ACS cases, it's thought, and SCAD affects women in greater than 90% of cases. Doesn't mean it doesn't affect men, but it's primarily a disease of women. All races are similar in terms of racial distribution, and it's believed it accounts for heart attacks in up to a certain large percentage of people under 35% of heart attacks in women under 50 years old. Now, what causes SCAD? Why do we develop this? Histopathology, I think I told you, SCAD is defined by the presence of a hematoma within either the dissected media or in the median external elastic laminate, and it compresses the arterial lumen. It's actually interesting. It's not an arterial dissection we think of in terms of communication with the lumen or the dissection itself. It's actually quite rare that the lumen and the dissected area would have a communication. It suggests that there's a structural problem within the arterial wall, within the media, that plays a critical role in these cases. However, histopathological investigation of SCAD, despite its somewhat not uncommon occurrence, are limited to 100 case reports, and the pathophysiological mechanisms driving SCAD remain insufficiently elucidated. There are risk factors we know, but there's no way to predict who will get SCAD and when. So it's a real problem. Now, this is the mechanism data. You can see that the idea, of course, is the inside-out hypothesis is there's a dissection that enters the subintimal space from the true lumen and causes a hematoma. That's less common in SCAD. In fact, most cases of SCAD are probably outside in. That is, there is a hematoma within the arterial wall that forms, and it may or may not dissect back into the lumen, but the hematoma is primarily the problem, the major problem. Now, what do we know about the genetics? We certainly know extracellular matrix is a critical determinant of vascular wall structural integrity and elasticity, and recent genome-wide association studies of SCAD have revealed involvement of SNPs involved in ECM-related genes. Mainly the extracellular matrix is important with SCAD. In the minority of cases of SCAD, and thought to 5 to 7% of individuals harbor rare variants. That is uncommon genetic variants within genes that have evidence of pathogenicity and may or may not be associated with syndromic or non-syndromic forms of disease, fibromuscular dysplasia, for instance, or aneurysms, things like that. In Walden multicenter cohort of individuals, a subset of 94 individuals had SCAD with high-risk features, and these were defined as peripartum SCAD, recurrent SCAD, individuals with family history. And so that was, in this subset, rare variants were identified in 16 of 94, so 17% of individuals. And these were in genes that are, common in the matrix, extracellular matrix, collagen 3A1, for instance, TGF-beta, SMAD, these are all TGF-beta related signaling mechanisms of fibrosis or matrix production. In the majority of cases of SCAD, no clear variant can be found, suggesting perhaps a polygenic etiology consisting of a collection of common variants. And the polygenic risks of SCAD is actually not that well explored, but one study analyzed families with SCAD, 27 affected, 13 unaffected, individuals with sporadic SCAD, so the SCAD that was not familial in nature, and healthy controls. And compared to healthy controls, the odds of being an affected family member having sporadic SCAD was significantly associated with SCAD polygenic risk. So there were multiple common risk variants that were higher in these patients of SCAD. And the association was not seen for unaffected family members, suggesting that to some extent, these genetic risk factors were sort of causal in the presentation of SCAD. And affected individuals with family did not share any rare or deleterious variants in these connective tissue-associated genes. So this sort of summarizes the issue with SCAD. SCAD is a complex disease. It's not clear it's got familial clustering across multiple generations. In some cases, yes. Majority of cases, no. So it's a multifactorial disease. It's not common. It's not clear what causes it. Meanwhile, current estimates 5 to 70% of all cases of SCAD have a monogenic etiology. So those are people with rare variants that harbor, defects in things like collagen 3A1 that would probably predispose towards SCAD. Now, we wanted to look at this relationship and study in a systematic way in a pathology database and look at the mechanisms linking genetics to the pathology of SCAD. And this study is one of the first to clarify the impact of pathological genetic variants in candidate SCAD-related genes on the histopathological and morphological properties of human SCAD lesions. Now, the study was based upon our large database of human autopsy lesions that we've collected for many, many years. As you can imagine, this was, it's not easy to get a lot of cases of SCAD together because they're fairly rare. So there were 944 hearts collected over the years, and it turns out that about 28 of those cases we had collected, these are sudden coronary death cases. These are all people that died. 28 cases had SCAD. And of those, really 20 had available histological and DNA assessment. And so we wanted to compare in this study a number of comparisons. We wanted to compare the culprit SCAD lesion in the 20 cases, and we wanted to compare to control cases. Control cases were cases of non-cardiac death, no history of SCAD. These people did not die of a coronary problem or a cardiac problem per se. They were just other causes of death, could be drug use, other things. But we needed to match those cases to the SCAD cases. And we also wanted to compare among SCAD, we wanted to compare the SCAD cases in the culprit vessel, so like, for instance, the LAD, to the non-culprit vessel to understand whether the pathology of SCAD is limited to the culprit vessel or there are elements that are also somewhat systemic in nature. Are there defects in, for instance, collagen in the culprit and the non-culprit vessel? And then we whole exome sequence these 20 cases to see what we could find in terms of genetic variants. This was the demographics of the study. 28 cases, all 28 here. I'm listing the age. You can see they're quite young. Majority are female, consistent with what I'm told you, 86%. The races were somewhat mixed, actually a higher percentage of blacks than what's been reported previously, and very small number of coronary artery disease risk factors. As you can imagine, about 14% of the cases had fibromuscular dysplasia. And I just want to highlight that the extent of dissection, 75% of cases had single vessel dissection, but 25% had multi-vessel dissection involving the left main trunk or the LAD, proximal LAD, et cetera. So think about this as severe cases of SCAD. These are all people that died from their SCAD lesion. Therefore, there'd be much more evidence of severe dissection in these cases. This is somewhat similar to previous studies that have been performed, although really nobody, on my search of the literature, has performed such a systematic analysis. Now, this is the first finding I wanted to highlight for you. So the location of the dissection in the media and the arc dissected, where was the dissection located? Between what portions of the arterial wall? You can see the majority of dissections were located, 86% were located between the external elastic lamina and the medial border. There were far less location of dissection in the media itself or outer or inner media. So really the EEL media border was the location of dissection in almost all the cases. And in terms of the arc of dissection, you can imagine these were very severe cases. So, you would expect the arc of dissection to be fairly large. That is the amount of dissection in terms of a 360-degree plane. And you can see in 55%, there was a 271 degree to 359 degree arc of dissection, and in 23% of cases, the dissection was actually 360 degrees in location, showing you that these were actually very severe cases. Now, this was a comparison between, remember, with first analysis we wanted to do was compare the arteries between the SCAD and control case lesions and see whether there were differences we could detect in the media itself. This is just a matching strategy, basically showing you there were no differences in the SCAD and control cases in terms of clinical risk factors, et cetera, just to show you the cases were well matched. And of course, these were young people, on average 42, 41 years of age. Now, is atherosclerosis a risk factor for SCAD? Was there more atherosclerosis? What we actually found is here we're looking at the control atherosclerosis cases, the culprit SCAD atherosclerosis, so the culprit vessel itself, and the non-culprit. And there were no significant differences in the patient cases I told you. And, lesions, atherosclerosis greater than pathological intimal thickening was less in SCAD than control. So actually, these people had less atherosclerosis to some extent, or less severe atherosclerosis than the other cases, the control cases. So it's not really a disease of advanced atherosclerosis. None of these cases, a minority, had anything close to high-risk atherosclerosis. You can see the number of fibroatheroma was almost non-existent. And we really had early atherosclerotic lesions. We described this as PIT, pathological intimal thickening, or adaptive intimal thickening in the majority of cases, just showing you that. Now, this is an interesting finding, evaluation of the media within the three groups. We wanted to look at collagen in the media using Mason's trichrome, which stains collagen, as you know, blue, or Sirius red, which is another way to look at collagen. And I want you to highlight for you the control case down below. The control case, you can clearly see the media has a fair amount of collagen as indicated by either the trichrome or the Sirius red staining. And you can see that within the non-culprit SCAD, so the non-culprit lesion or the culprit SCAD lesion, the media was fairly devoid of collagen, completely different between the media of the control cases and the culprit and non-culprit SCAD cases. So in terms of statistical analysis, there was significantly less collagen found in culprit SCAD cases versus controls in the media, indicating that collagen deficiency was an important marker of SCAD. However, when we looked at the difference between the culprit and the non-culprit lesions in the SCAD cases themselves, there was really no differences in the amount of collagen found, showing you that to some extent, even non-culprit arteries had a deficiency of collagen. Now, in terms of smooth muscle cells, we wanted to classify the smooth muscle cells and say, are they actually different in any way? We use smooth muscle actin as a marker of smooth muscle cells in general. And what we found was that smooth muscle actin was really not different between any of the cases. The control case, the non-culprit SCAD, the culprit SCAD lesions all had similar amounts of smooth muscle actin. Now, we also looked at smoothulin. It's a marker of contractile smooth muscle cells, so a certain form of muscle cells. And you can see when you look at the control, non-control lesion, the media, it's darkly stained by smoothulin, indicating those are all contractile smooth muscle cells within the media. We looked at smoothulin degree in the media of the non-culprit SCAD and the culprit SCAD cases. You can see that smoothulin staining was much less, suggesting there was some sort of smooth muscle phenotypic transformation even with the non-culprit lesions in these cases. And you can see here the culprit SCAD and non-culprit SCAD, you can see that in terms of the way this muscle cell looked, the height-width ratio was extremely different in the culprit and non-culprit SCAD cases than in the control cases. We did whole exome sequencing to look at how many of these cases harbored important rare genetic variants. And so we filtered these cases by Franklin, and we found, in fact, that of these 20 cases, 6 harbored pathogenic or likely pathogenic variants. The rest did not carry any pathogenic variants. And here are the pathogenic variants found. You can see they're expected in genes that are expected: TGF-beta, collagen 3A, FBN1, PKD1, and FLNA, where the genetic variants, the severe genetic variants existed. And these are the cases. You can see that of the 20 cases, actually, we found genetic variants, rare genetic variants, pathogenic. In 5 of those cases, 1 person carried 2 severe genetic variants within their situation, but the rest, so really it was about 20% carrying these severe or pathogenic genetic variants. And you can see it's interesting. We looked at multi-vessel disease SCAD between carriers of pathogenic, likely pathogenic variants and non-pathogenic variant carriers. And pathogenic variant carriers were more likely to have multi-vessel dissection SCAD than non-pathogenic variant carriers, suggesting a more severe phenotype if you carried rare pathogenic variants. And these are just showing you individual cases of the collagen 3A variant. For instance, I'm showing you control on the left-hand side. We're looking at smoothulin as alpha-muscle actin, and then we're looking at, and these are the cases on the below, and then the controls on top. And you can see here we're looking at serious red, collagen 3, and collagen 3 acta 2 double staining. And what you see is, in fact, if you compare the SCAD to control, there's an absence of collagen 3A consistent with the genetic variant this person carried. And then here's another case of a SCAD FBN variant in control, which I'm showing you. Similarly, the fibrillin 1 gene, which was the gene of defect, is almost absent in the particular SCAD case versus the control case, showing you and verifying the genetic variant. And this was FLN1 collagen A2 variant, showing you again this kind of similar absence of collagen in this particular case, and filament A as well is fairly absent from the media in this particular case. So in summary, in this study, we histologically examined the collagen content muscle cells in the tunica media and examined DNA variants. I think it's the first systematic study, if you can believe it, to correlate genetics to vascular pathology in the case of SCAD. We report two novel findings. First, reduced collagen content in muscle cell phenotypic modulation were absorbed in the tunica media of subjects with SCAD versus control, and the reduction in collagen was not limited to the culprit lesion in SCAD, but appeared in non-culprit vessels as well, suggesting perhaps a systemic process. And secondly, pathologic variants were such with a higher prevalence of multi-vessel dissection and expression of proteins encoded by the pathogenic variants were reduced in the media, in SCAD cases carrying these variants. And these integrated results using both histological and genetic findings may collectively further our understanding of the development and risk progression of SCAD. And I think these results, really clinical take-home, highlight the need for genetic evaluation, particularly in patients with a family history of multi-vessel SCAD, to identify individuals with increased risk. But the need to better understand the causal genetic mechanism underlying SCAD is certainly very important in terms of understanding and improving our way to care for these patients. So with that, thank you so much for your attention.
Okay, thank you. Is my microphone on? Yeah, thank you very much for this amazing presentation with such in-depth pathological analysis and genetic analysis, leading to a really important conclusion where you can move forward towards screening and therapeutic targeting, and targeting this devastating event when it happens, even if it's the prevalence is not as much as conventional coronary disease. Is still a very important and devastating disease that kills young women mostly. So I'll open the floor to questions. But first, was there kind of, when you're doing the autopsies in these women, did you find any general morphological changes away from the arteries that might lead you towards SCAD in context of the deficiency in collagen and the fibrin issues? Was there anything else in the skin, for example, or in the eyes, or anything else?
Yes. So when this paper's under revision at a journal, but we were asked about, specifically we were asked about the use of FFPE and whether that could degrade DNA, leading to false positive identification of pathologic variants. And that was because we had identified, as you saw, 5 individuals with pathologic variants. So we went back, we were not able to contact family members, Ramsey, as you could imagine, because of the complexity of this kind. These were collected over many years, and it's not that simple just to go back and conduct genetic testing on decedents, because you would need some, genetic counseling. You need to arrange for a lot of things, and we're not licensed for genetic testing. But we did look at the individual family histories of the individuals. And a lot of them, I'd say 4 out of the 5, one had a diagnosis of collagen 3A known. So that person was known having collagen 3A variant. The others had family histories or histories, personal medical histories that were consistent with the disease, like FLNA is associated with mitral valve prolapse. That person had some report of mitral valve prolapse, and there's some other, for instance, the fibrillin 1 defect, there was some evidence of somebody dying of an aneurysm in the family. So I think there were suggestive histories in some of these genetic cases. It's just that they weren't necessarily keyed upon. And then you could ask the other question, Ramsey, so we found a genetic variant in some of these people. Even if you were able to find it ahead of time, what would you do? How would you predict the SCAD, and how would you know how to treat it?
Yeah, so I mean, I guess there's a question from the floor, but just very briefly to follow up, how prevalent are these variants in normal individuals in this in kind of?
No, these are not prevalent in normal individuals. So these are very rare variants. These are uncommon, like less than 0.01% of individuals would harbor these variants, and these are shown by Franklin to be pathogenic. That means they have some important product, effect on the protein itself, making it essentially either non-expression or dysfunctional, so non-functional. And you saw that in all the cases we had done specific staining for the protein of interest, and it really didn't exist in the media. So I think that was, these are rare variant carriers, but you could see in 15 of the 20 cases, there was no evidence of a pathologic rare variant found. So probably polygenic etiology.
So we'll take a couple of questions from the floor.
Thank you very much. You actually, I understand the focus here is on genetics, but I'm wondering if you're also looking at the circulating, the omics, the metabolomics, the proteomics, just to get sort of an additional insight in terms of, the underlying, of course, it would really be interested to see what sort of causal mechanisms are at play beyond genetics.
Yeah, but that's a great question. And I think that, the problem with collecting, for instance, proteomics, blood proteomics, or other aspects is, of course, the collection of these cases. These were 28 cases that were gathered over the course of 20 years. So, it's hard to have a biobank which collects those in a systematic manner. We have not done that. I think your points are very well taken and very interesting, but I'm not even sure it's feasible. I should say that all the other, there are multiple papers on the genetics of SCAD that have been published. Most of those contain non-pathology, and they're people that survived the SCAD event and are still living. So our results are a little bit different from what other people have presented in terms of the percentage of pathogenic variants. But as you can see, the pathogenic variant individuals presented with more severe forms of the disease, suggesting that that's a risk factor for death or even more multi-vessel SCAD.
Yeah. Well, on that, Alok, it only remains for me to thank you and the team at CV Path for a fantastic presentation. Please give everyone at your institution our very best from Imperial, and especially Dr. Vimani, who we hope that next time you'll be able to join us here in London instead of being online. And thank you very much again, and have a good day ahead of you. Thank you.
Perfect. Thank you so much for inviting me. Really a pleasure. Thanks.
It's a real pleasure. So it's my pleasure to ask my friend and colleague, Professor Rasha Lami, to come up and give us a talk on angina in women. Rasha, thanks for leaving the cath lab and being with us.
No problem. Thank you very much. I'm afraid after I give my talk, I'll have to rush back to the cath lab. But I start with a big disclosure, which kind of follows on from Barbara's conversation, which is that for a long time, I'm just trying to advance these slides. Yeah, perfect. For a long time, people have felt that, women present differently with angina. They have a very, very different pathophysiology. I'm actually not sure about that. And I'm not sure about the data that leads us to that point. We talk a lot about microvascular dysfunction, and people talk about it as this tip of an iceberg. And myself and my group have started to call it the tip of an ice cube. We're not sure that the problem's quite as big as people make it, or certainly it doesn't seem to be when I'm in clinical practice doing some of these cases. But in any case, I'll speak to the kind of literature as it sits out there. And of course, as I said, I'm a bit of a skeptic about this literature. Let me stand in the middle so as not to block. So the literature will tell us that many patients who come to the cath lab who are women and have chest pain outside of that cath lab then have an angiogram that shows unobstructed coronary arteries. And they would then say they are very highly likely to have microvascular dysfunction, and they give you these crazy rates of women with microvascular dysfunction. The problem is that this has been unsystematically studied, and they are often studied in very selected cohorts of patients in specific clinics, such as women's cardiovascular centers in the US, etc. And when you systematically try and study it, as we've been doing in our cath lab, we seem to get rates of somewhere between, we did it for a couple of months, of somewhere between 5 and 10%, much lower pickup rates. Now, you might say that that's because the patients that come to our clinic come with a CT coronary angiogram that's already taken only patients with coronary disease into our labs and sub-selected a whole bunch of patients that don't make it into our labs. It's possible, but we're not seeing it in the rates that people speak to. People also say that in women, many of them continue to have angina despite good medical therapy. But I would argue that there's a lot of issues with the evidence base as it sits at the moment. So classically, all of the angina randomized controlled trials that we do, including the ones we've done in our labs, have recruited somewhere around 20% of their population being female. And that's for a variety of reasons, including some that Barbara alluded to, which is the difficulty of actually just getting women to be part of clinical trials. I'm, of course, a woman going out there trying to recruit women into my trials, and I find it as hard as any of my male colleagues. So there is an issue in terms of getting women to engage in our cardiovascular research. And importantly, some of the treatment paradigms that sit around angina sit around predominantly male populations because that was the evidence base that they had. We don't know if there's sex-specific treatments that are possible for women. It's never really been done. And there has recently been a very large grant call looking at exactly that. So perhaps in time we'll have that, but we don't have that now. And importantly, when you look at the trials that have looked at microvascular disease, which is obviously supposed to be much more prominent in women, what you will find is that the criteria for diagnosis of microvascular disease are really woolly. And in fact, most of those trials that exist, if you look at the current criteria for microvascular dysfunction, only about 25% of those patients would have made the criteria based on the new guidelines that we have. So it's a real problem that we don't have the data, and we perhaps over-extrapolate the size of the problem because we just don't know. So I'm going to talk to you about a case, just because I think it's helpful to think about these cases as you think about the database. So this is a 67-year-old woman who came into our cath lab that I saw some time ago. And as you can see, she had presented multiple times with classical angina, had multiple episodes of coronary stenting because she had significant epicardial coronary disease. It was hard to get lots of the data on these many angiograms and angioplasties that she'd had because many were done outside of our hospital. So it's hard to know exactly what the coronary anatomy was that had led to all this stenting, but you can see she'd been in many times and ended up with stents in all 3 of her main coronary arteries. And she'd come to us in clinic with more chest pain. 2 months history of chest pain that she described as tight and central, sometimes a left-sided dull ache, sometimes related to exertion, sometimes it was happening at rest. She said this was very similar to all of the previous presentations, and you can see that it had some level of typicality for cardiac chest pain and some quite atypical features. She also had some occasional breathlessness, as many of our patients do. But also importantly, she had lots of other things that you will also find quite commonly sometimes in our women with cardiac disease. She had obstructive sleep apnea, she had a high BMI, she was depressed, she had some problems with hearing impairment. But importantly, she also had risk factors for coronary artery disease. She was on a multitude of medications, including risk prevention and 2 anti-anginal agents. And I kind of want to bring us back to kind of where she is now. So we talk about angina as if it's, all chest pain that presents to the cath lab is cardiac. But I would argue that, and you'll read in the literature, causes of angina. Well, I would argue angina is cardiac. and that many of these patients that come to the lab will have all sorts of reasons why they have chest pain, and some of them will be non-cardiac. And it's important to remember that as you guys think about what trials or what studies you're going to do. Not every patient that comes to the cath lab with chest pain and has unobstructed coronary arteries has a cardiac cause for their chest pain. They may just have musculoskeletal pain or something else going on. And angina in itself is incredibly difficult to assess. We do it all the time in clinical practice, but it's hard to ask the questions in a systematic way. The patients understand questions differently. Of course, there is a heterogeneity in how they respond depending on language barriers or cultural barriers. And some of that may be sex-specific, actually, and perhaps we need to study it a little bit more. But importantly, as such a kind of subjective endpoint, it means that some of the trials that we do and conduct in assessing this can be really complicated. And the other bit to remember is that, as I said, angina is in itself a cardiac condition. But once we've got to the point at which we've decided this angina is cardiac, it can be caused by epicardial disease, very commonly, but of course also from abnormalities in the microcirculation, of which there are of course structural and functional mechanisms for this happening. And this happens in men and women, but is supposed to be more prevalent in women, that they might have microvascular dysfunction. So making the diagnosis is really hard, right? And you make that diagnosis in clinic, you think that they have angina that's cardiac. In our pathways, we would do a CT coronary angiogram in the vast majority of patients. If they have unobstructed disease, we will send them off, which means we don't necessarily do any assessment for microvascular dysfunction because we've already decided that anatomically they don't have coronary artery disease. And then there will be some patients who make it to the cath lab, and at that point, we may do some more tests. Now, of course, somewhere in our pathways is the option to do ischemia testing, so functional testing, but that's a bit variable. Who gets a functional test can be quite variable in the various systems. So this lady had a stress perfusion CMR. And on her stress perfusion CMR, and obviously I'm not an expert of this, but there was said to be changes suggested of microvascular dysfunction. She had low resting myocardial blood flow, and this is kind of important to see. And then there were some regional wall motion abnormalities only at stress. And importantly, what they said was that her myocardial blood flow at stress was low at 1.7. So there's a sense of some issues with her coronary flow or her myocardial perfusion, and so she comes to the lab. So remember, she had stents in all three main arteries, and for those of you who haven't studied coronary angiography before, essentially her stents are unobstructed. She has some mild coronary artery disease elsewhere, but there's nothing there that makes us think that there's a slam dunk issue that we need to now stent, and that's in all three of her arteries. Now, she has a kind of mild to moderate mid left anterior descending artery lesion, but as I said, nothing super terrible. And then the right coronary artery the same, so mild distal disease, but otherwise patent stents. So the question is, what do you do? Do you just say, you're fine, don't worry about it? You've come in multiple times, you've had loads and loads of stents, you've still got lots of chest pain, we don't know what's going on. Or do you do some assessment? So we're pretty bad often at doing any more assessment of these patients. We often do just say, you've got unobstructed arteries, it's not my problem, off you go. But these days we are told to do invasive coronary function testing and try and work out what's happening with these patients. And the reason we do that is because anatomical assessment has lots and lots of limitations. It just relies on our eyeballs telling us whether someone's got coronary artery disease. Doesn't tell us if there's a problem with the microcirculation. It doesn't tell them if they have problems that would hemodynamically come about, such as vasospasm, if we were to give them the right drugs. And so in this patient, I wanted to think about more. Of course, it's possible that some of her chest pain is from epicardial disease, but we don't really see it on the angiogram. It's also possible that she has a combination of epicardial and microvascular dysfunction. And it's also possible this, in this moment, is just microvascular disease. We have lots of different ways that we assess it, and I won't kind of focus on these today, but one of the major issues that we have is that we use binary cut points to decide if someone's got ischemia or they have microvascular dysfunction. And I would argue that ischemia in these patients sits on a continuum. But in any case, the guidelines and the trials would tell us we should use these sort of static binary numbers. The general paradigm now to try and assess these patients better is that as soon as you've done your angiogram, you would then take a pressure wire, pass a wire down. You could do it into all three coronary arteries, but the sort of general rule is that we do it in the left anterior descending artery because that's the one that will have the most flow in a normal patient and would be the most likely to have abnormal flow if they have microvascular dysfunction. You do lots of assessments, and then importantly, what we're supposed to do is vasoreactivity testing for vasospasm, because of all of the different subtypes of microvascular dysfunction, this is the one that has a specific treatment in terms of calcium channel antagonists. The others, in general, any anti-anginal agent might work, but this is the one moment where you might change your treatment. Fortunately, at the Hammersmith, we don't have access to acetylcholine at the moment, so we can't do these tests. These are the diagnostic criteria for coronary microvascular dysfunction, and they're the kind of classic criteria, but as I said, in most of the trials that you read about, they didn't apply these criteria. They're much newer, and so many of the patients that would have made it in previous INOCA and ANOCA trials would not have met these criteria. So with this lady, what do? Well, we pass a pressure wire down the LAD, we do a bunch of tests, and she had Doppler flow to look at her coronary flow reserve, and remember I said the cut point is 2.5, anything less than that is microvascular dysfunction, and hers was 1.9. She also has bolus thermodilution measurements, which are a sort of much easier way to measure for CMD, and it's quite interesting because her CFR here is 2.6, so it's kind of on the cut point, but not as low as it was on Doppler. But what is interesting is her IMR, so her index for microvascular resistance, is high. And so it makes us start to think, and remember the cut point for that was 25, so it makes us start to think that this woman's got structural CMD. Importantly, because she also had a lesion in her left anterior descending artery, we also measured the pressure gradient for her epicardial disease, and that was also low. So there was a kind of combination of things happening with this lady. So as I said, there was a kind of, some of the numbers that we got, that Doppler wire CFR was different to the CFR that we did on bolus thermodilution. I mean, this is perhaps not of interest to you guys, but for interventional cardiologists, it's important to remember that the number that we generate with bolus, which is our easiest tool, the one that we use all the time, the one that's in classic clinical practice now, is very, very variable, essentially a random number generator, and very often overestimates the CFR in these patients. So that's a real problem if you're starting to think about studies. But what happens next? Well, now what you can start to do is say, well, how can we target her treatment? Now, as I told you, I wasn't able to look for vasospasm in her, but I think it would be unusual to have epicardial disease, microvascular dysfunction, structural CMD, and also vasospasm. So luckily, although we didn't have the test, I'm going to say it was probably unlikely that she had it. So we now have ideas around targeted medical therapy. And this was probably the kind of classic trial that would tell us that if you target your medical therapy based on the type of CMD a patient might have, you might be likely to have better results. There are lots of limitations with this data, and that's kind of for another study, but in any case, there's some idea that we should start to think about exactly what we give to these patients. So in summary, what did we do with this woman? Well, she basically got another anti-anginal, which is probably the classic thing to do with many of these patients because we don't currently have any better way to treat them. And there might be new therapeutic agents that come in time, but so far, all of the new agents, and the most recent ones was zibotentan, have been negative in this population. They haven't worked. So in time, again, another area of study is where could you get to a point where you have targeted therapeutic agents? But I would say that this woman had obviously epicardial disease and now structural CMD. So what my take-home message is, well, I'm not sure if I've made things easier or harder to understand, but basically angina in women is probably as difficult to understand as it is in men. It's harder because they have not featured in many of our trials and because we've probably overestimated the size of a problem in terms of microvascular dysfunction in these patients, or at the very least, we just don't know what the size of that problem is. I think in many of these patients, in many cases in women, they will have a combination of things going on, but so too in men. And of course, as I said, any kind of sex-specific management paradigms just don't really exist, and we're kind of waiting for more data to work out whether that's actually important and might change outcomes in women, or whether that's actually something we should leave alone and we should treat women as we treat men. We really don't know, and so I'll stop there. Lovely, thanks.
Thanks, Rasha, for, as always, a wonderful talk and comprehensive summary, and also just really a preview of how difficult it is, and even with advanced interventional methods, there is still difficulty in reaching final diagnosis. So it kind of really sets the stage for further work. So we're a little behind, but I'd like a couple of questions, if you don't mind, from the floor. Jamil?
Rasha, very nice talk. Angina is difficult in women, it's difficult in men. And we tend to go in cycles here. So Mazari, who was at the Hammersmith, even when I was a medical student, put LNMA and acetylcholine down coronary arteries and worked in this area. It's a vague, nebulous, difficult area. I would encourage our generation not to go down this path. Yeah. We just go around in circles and circles. And there's stable angina, myocardial ischemia, anatomical coronary disease are not the same thing. Yeah. They're separate things, there's an overlap, but we tend to conflate them, and that's a major problem. Having aches and pains is normal in human beings. Yeah. And I think that slide you said with non-cardiac and cardiac things, the majority of patients don't have any of that. Yeah. They have aches and pains. And I like to tell patients that we don't know. I draw an analogy to headaches. And in that specific patient, I think that poor lady who's going round in circles. So personally, my practice is, I think it's really important to make a clinical diagnosis of angina, and that's done in the bedside or in the outpatient clinic. Is there a relationship with the pain to exertion? Does it go away when you rest? Is that consistent or not? And I think you need to be really clear in your mind whether you think this patient's got angina or not. Doing the other test doesn't necessarily help with that. It can maybe lend a little bit of support, but that's really, really important. If the patient doesn't have anginal pain, I think you need to talk about different things. These patients will often get a CT coronary angiogram. It'll often be normal. And then my practice is to reassure the patient and say, we are uncertain what the cause is. It's normal to have aches and pains. If the patient does have anginal pain, I have to say I keep an open mind of the normal coronary arteries. I use anti-anginal medicines and see if it helps or not as a symptomatic thing. I think your work on actually trying to help support the diagnosis of angina, blowing up balloons and seeing the pains reproduced, that's really, really important work. And I think that's where our effort should be directed towards, not microvascular, which I think we're just making the same mistakes as we have done previously. Yeah. But I'll just encourage you to keep going with that, but not be distracted into this.
Yeah, well, I'm solidly not distracted. In fact, we have lots of various ideas around. We call it the Inoka drive-by. My idea is to actually tell everyone that this disease is not as big as we think, but also importantly, until we have targeted treatment, if that would ever exist. I mean, you could argue with this woman, you could have just given her ranolazine to begin with, right? And save everyone a lot of heartache and a CMR and an angiogram and a bunch of pressure wires and actually the risk of that procedure. But, this is... So what we have done in our research is we've added microvascular assessment into all the trials now. The reason being, because what people have often said is, the reason stents didn't work is because there was coexistent microvascular dysfunction in these patients. I don't think so, because we're doing those tests at the moment and we're not finding it.
I think you have to measure it. Yeah. I think that we cause far more problems in this area.
Totally.
I remember as a junior going to a women's chest pain clinic, I won't say where it is, and basically these poor women came in who had non-cardiac chest pain, normal coronary arteries, and were labelled as having cardiac pain, and not surprisingly, anti-anginals didn't work. Yeah. And if we're not clear thinking about how we manage patients, if we don't talk to patients properly in the clinic and explain things, you end up, a lot of patients have ended up becoming cardiac cripples for no good reason because of us.
Yeah. Rasha, just to follow up briefly from your experience on the Orbiter 2 study, because you've got the app and it's a really good way to track effect of treatment versus placebo. Yeah. Did you see a difference between men and women?
Zero difference.
Zero difference.
So I didn't talk to that today. So we looked at typicality of angina. That was the same in women as it was in men. There's often these studies that women are more likely to present with atypical pain. That was not what we found. In terms of treatment effect from PCI, it was identical between men and women. And if they had atypical pain, the stents didn't work as much as men as in women. The problem is that obviously women only made about 20% of our trial population in a pretty small trial. So, you could argue we were kind of underpowered for that. But so far, I'm not sure that much of what we've done in terms of kind of targeting, I'm worried that women won't get statins and treatment for coronary artery disease and prevention because we'll assume that women don't have the same disease as men, and I think we don't have the evidence for that yet.
So on that comment, I'd like to thank you again, Rasha, for the wonderful talk and the great discussion. We're 10 minutes behind, so we could have spent the whole day talking about that, but we're going to move on to an exciting talk by Catherine McGurk, who's a cardiovascular geneticist that is a British Heart Foundation Immediate Fellow, working both at the MRC and NHLI. And she's going to talk to us about sex differences in the penetrance of cardiomyopathy genetic variants as soon as she's mic'd up. So welcome, Catherine.
Thank you. Can you hear me? Shall I give you a second? Does it work? Great. So back to genetics, and I wanted to set the scene a little bit for why understanding penetrance is really important. Genetics is becoming more and more accessible. You can apply yourselves to consumer-initiated genetic testing, but the US has actually pushed reporting DNA variants without indication since 2013. And this is the American College of Medical Genetics, and it's based on a different healthcare system. So they say that you should report secondary genetic findings in the context of clinical sequencing for a list of 84 genes. 50% are cardiovascular related and 20% are due to 2 cardiomyopathies that I'm going to talk about today. You can imagine there are problems here, and an example is you go for breast cancer genetic testing and you find out you have a titin truncating variant. The UK has been cautious and so has Europe, but there is a large initiative coming out now by the Department of Health and Social Care that by 2035 they expect that half of all healthcare interactions will be informed by genomic insights and other predictive analytics, being AI. And they say that genomics and predictive analytics can increasingly tell us the likelihood of a person developing a condition before it occurs. This is not the case for individual variants associated with cardiomyopathies. And cardiomyopathies are collectively common diseases found in 1 in 500 and 1 in 250 individuals, but they're caused in 30% of the time by individual rare variants. They're the leading cause of heart failure, sudden death, and an indication for heart transplant. And hypertrophic cardiomyopathy has this thick left ventricular wall, and dilated cardiomyopathy has that large ventricular volume. But about 1 in 500, 1 in 250 individuals of the population. So we need to understand penetrance of these variants. Penetrance is the probability of developing disease given that you have a particular variant. Importantly, this is down to diagnosis as opposed to severity or expressivity. And so in that top right corner, if all 7 of those individuals had the same variant, they would have complete penetrance, or all of them are diagnosed within their lifetime. But most of the time, even for variants that we know can cause early onset disease, we see variable penetrance in the general population. Maybe only 3 of those 7 individuals ever get diagnosed with a cardiomyopathy. This can be because of the consequence of the variant on function. If it's a missense variant or loss of function variants or more penetrance, can be due to the environment modifying genetic evidence. This can be, which is where we bundle age, sex, other cardiovascular risk factors, hypertension, for example. Additional genetic variants, there's been some discussion about polygenic risk, or you might have a second hit, a second monogenic variant that puts you over the threshold for disease. And sometimes there are these interesting papers out showing that there's allele expression differences too. Sometimes pathogenic variants are just less expressed than the wild type copy. And you can imagine there are different scenarios where the penetrance estimates will change. In the population, they haven't gone to the clinic, so likely that the variants you find are more common, less penetrant, so they are less likely to ever have disease. But obviously this estimate of penetrance increases when you've got a family member with the condition, and you've got shared genetic and environmental factors, or if you're only looking at cases. But really importantly, and I hope this helps more of the clinical people who just get a genetic report, that pathogenicity is not the same as penetrance. So pathogenicity is about whether the variant seen in your patient explains the etiology of the individual. You have to have some association with disease, and then it's given some label about the evidence to support it, whether it's pathogenic, variant of uncertain significance, or benign. And once you know the variant is pathogenic, then you can estimate penetrance, the probability of future disease in an asymptomatic individual. And then hopefully the aim of estimating penetrance is what is modifying these individuals to put some individuals over the threshold for disease and not in others. So just importantly, a benign variant is not low penetrant. So where are we moving? Well, ideally, if you found a carrier of a variant of interest in an unselected population or as a secondary finding, or maybe in 2035 when they show up with a time truncating variant, if they haven't manifested disease off a one-off cardiac screen and the variant has low penetrance, the patient might be able to choose less frequent surveillance. So it really helps those long-term surveillance and screening strategies in cardiomyopathies. And ideally, given their age and their sex, we could estimate this a bit further. And so myself and Declan Regan and James Ware and Antonio DeMarvo published this early study in UK Biobank where we had 16,000 individuals with MRIs and genetics. And we showed that pathogenic variants in hypertrophic cardiomyopathy that if you saw in a case would indeed be thought to be the cause of their disease had incomplete penetrance in the general population. And only 18% of individuals actually met a threshold of disease that's quite relaxed for hypertrophic cardiomyopathy. And because of today's focus on sex and women, while the male subjects did indeed have higher overall risk of adverse outcomes, having a pathogenic variant had a lot larger of an increase in risk comparing genotype negative females to genotype positive or pathogenic females. So variants are important indeed in stratifying females. And in our seminal paper in the American Journal of Human Genetics, we had access to 13,000 cardiomyopathy cases and their genetics and over 300,000 individuals of the population. And we estimated penetrance in a cross-sectional approach that's not just in this kind of UK biobank. They've all survived to 40, 69 years old to be recruited, but it gives a better estimate of penetrance. And we were really wanted to incorporate the uncertainty. So for a particular variant, we're not that sure in the penetrance. We wanted to incorporate that. But you have to have a good gauge on disease prevalence, which I'm going to come back to, and then frequency of variants in cases and frequency of variants in the population. And we did see that pathogenic variants were more penetrant for hypertrophic cardiomyopathy in men. And for some individual variants at the time, we were able to see some differences by sex. Some variants were even not observed in population males. And we'd love to repeat this analysis for more variants, but also for the much larger sample sizes we have now. Work led by Paz Tayal, who unfortunately couldn't be here today, has shown that when we looked at the penetrance in DSP, so a gene involved in cardiac mechanical stability and dilated cardiomyopathy, we saw an increased burden in female cases compared to men. And then when we looked in the general population and did our estimates of penetrance, we indeed saw this increased penetrance in females compared to men. So there is some sex-specific penetrance going on, as well as differences in disease prevalence. And just to touch on this really lightly, that hypertrophic cardiomyopathy is always flagged in literature as 1 in 500 and dilated 1 in 250. But if you actually meta-analyze the papers and exclude those papers where the individual is particularly elderly, particularly fit, for example, you actually see that it's slightly rarer for hypertrophic cardiomyopathy and slightly more common for dilated. And if you split by sex, it looks like a 1 in 4 diagnostic ratio for hypertrophic cardiomyopathy and 1 in 2 for DCM. And Paz's team have just published, we were involved, and Lara, who's here too, published in Circulation, looking at this difference in diagnostic thresholds. And this 1:2 ratio was seen for all-cause disease, genotype positive, genotype negative, case cohorts, population cohorts, and even if you apply sex-stratified imaging criteria. So is there an underdiagnosis in females? They often present with less severe cardiac phenotypes, lower levels of fibrosis, and better function. You know, it might be strange to try and even think about pushing this towards a 1:1 ratio, but the problem is there's still worse outcomes in women. So women with hypertrophic cardiomyopathy have worse survival and they're at higher risk of mortality and developing severe heart failure symptoms. So ideally, even if we could use genetics to pinpoint those individuals at an earlier stage and put them under screening and let go of other individuals who we might have just recruited and didn't want to let go of because we didn't know their penetrance. So there's a need for increased confidence in sex-specific disease prevalence and better diagnostic tools for women. There looks like there might be an underdiagnosis of women, but also sex-specific penetrance, and more estimates of penetrance are needed so that we can inform actionability for personalised care, but really make genetics more useful in the clinic. And ideally, we can then identify modifiers and Professor Ramsey noted some of these lifestyle modifiers, but also there's loads of genetics that we're not looking at. The X chromosome, men express the same X chromosome throughout their body. Women have 50% X inactivation. Mitochondrial DNA just excludes male selection, so if it's protective for women, the men get it too. BMI, cardiac aging, I don't think we have a total understanding of female and male-specific cardiac aging, and sex-specific GWAS, which might sound curious, but myself and Lara and Declan and Regan are thinking of doing, now that we have 100,000 individuals in UK Biobank, of doing left ventricular hypertrophy just in females, just in males. Would we find DSP, for example, in the females? Are there, obesity-related genes, or that we should be targeting more with obesity-related or more aggressively in men? Can we start exploring these differences by sex? So I have an ongoing fellowship application that's been submitted and some work. We've got 25,000 cardiomyopathy cases now, a lot more sex data. Global biobanks have quadrupled in size. So there's a lot more age and sex-specific answers we want. I've got a great student who's looking at health economics of reporting tight truncating variants in breast cancer patients. Can we set a threshold that would meet the NICE guidelines? Spoiler, it's not going to be very cost effective. That's from this morning work he did. And then obviously we can use the expososome or exposure-wide association studies like those in the top right corner to start teasing why are some individuals being diagnosed and others are not for variants that we're powered to do so. So just a big thank you to all our cardiomyopathy group, James Ware, Declan Regan, and Paz Tiles done a lot of this spearheading of sex-specific work.
Thanks, Catherine, for this really great talk and giving us an insight into kind of penetrance, which is, for most scientists and doctors, is something that's not actually, we don't know much about it. So it's nice to see an example of that. But what's really interesting here is that you're getting sex-specific difference in penetrance. And just when you were talking about modifiers, do you think kind of the recurrent stress induced in a woman's life, including as in like physical stress as a modifier, including pregnancy and perhaps menopause, are really affecting penetrance in the same way that possibly equivalent stresses would do in an XY chromosome fashion if you were to equate them in an experimental model, i.e. is this really kind of XX dependent phenomenon, or is it because women are undergoing these kind of specific specific stresses that are just special for women?
I'd love to give you a solid answer, but I think there's just more work that needs to be done. So I should, I've kind of emphasized here that most of the risk is in men for cardiomyopathies. And that DSP finding is quite niche. And I started, when we found this with Paz, I started saying, is it because we're missing all the men who've already had really severe disease, really early sudden death? But actually, a paper by Jodie Ingalls, our colleague in Australia, showed that when you look at the sudden death that occurs in these patients, it's 50-50 sex specific. So it's men and women who are having sudden death early. So I like to think there's something we don't understand fully about cardiac aging in women and men. And I think if we can start teasing that apart, maybe some of these variants put them over the threshold of disease. But I would love to say that we could start, it's all about, for me, is the impact, the health economics, the therapies now. Can we start targeting treatments specifically by sex? Yeah, it's a waiting game. I think we just need to bundle that research together, particularly by 2035, when all of these people are going to start finding out they have pathogenic variants. And they'll become a bit more of a burden on the health system.
Well, Professor Cassidy, you wanted to ask something? Or did I get... Yes, I read your hand coming up halfway and then coming down, but I'm making you speak.
I was, thank you very much, Catherine, that was great. I was just thinking of the way that we measure hearts, right? And so, for example, in heart failure, it turned up that, in the, traditional heart failure treatment, worked in women with heart failure with preserve ejection fraction because the ejection fraction wasn't really preserved because it's so dependent on the end diastolic volume. And so I wonder whether, it is the way that we measure hearts that is partly responsible for those differences in penetrance.
Yeah, I think the fact even that we're looking at kind of structural heart diseases, that meeting those thresholds of left ventricular hypertrophy in men, just from an image, I agree. I think it's definitely easier. I think, and then actually we did a great paper on cardiac aging, bringing loads of MRI phenotypes together to then derive a cardiac aging trait. And the differences between sex was obesity. Is that size again? Is it? But then I argued, because when I was talking about this GWAS idea of doing sex-specific GWAS, Declan said, what if we just find obesity? Well, then, we could Ozempic even more aggressively in men or get that weight lower. If it is to do with body mass, if it's to do with lower weight that can, save you a bit of risk because you have a pathogenic variant, I think that's a great outcome. I think there's just so much more we need to know, but I do agree. I think not having a proper gauge on the disease prevalence puts a lot of uncertainty into our penetrance estimates, never mind, treatment and, yeah.
So we take one more question.
Yeah, just going directly to Professor Castello's question, because Catherine brought up our circulation paper that Pascal led on, that we tried to look at this specifically in UK Biobank, where Catherine's already noted there is a big preponderance for men being overrepresented in cardiomyopathies, and whether this is due to some bias due to unadjusted thresholds, which aren't adjusted for demographics and age and sex. So we derived demographically adjusted thresholds for ejection fraction and volumes, and it did help to redress the sex balance. Clearly, as Catherine said, this is mostly monogenic disease with autosomal dominant inheritance. You'd expect a one-to-one penetrance, but it didn't go the whole way. So I think it's a combination of ascertainment bias, but also clearly there is some sex-specific modifiers of genetic penetrance as well. So I think it's kind of complex.
Yeah. Every adjustment under-adjusts.
Oh, that's a good discussion point. We should.
That's great. Thank you so much again. So we're only 10 minutes behind, which we will cut the coffee break for. So last and not least in this first session, it's a pleasure to introduce Aaron Sau, who is an academic clinical lecturer at the NHLI. Aaron is probably one of the most successful PhD students we've had over the past few years, and is now won, I think, pretty much every major award that can be given for a PhD. So it's wonderful to hear him speak today on AI insights into women's cardiovascular health and sex differences. Aaron, the floor is yours once you're all wired up. Good.
Thank you so much, Ramsey, for that introduction. So I'm going to talk a little bit about how we can use AI to potentially give us some insights into some of these problems that we're addressing today. Just some disclosures, including relevant co-founding interest in Cardiovol AI, which is commercializing some of the tools that I'm going to discuss in the talk today. So I won't spend too much time discussing this. We've covered it already at the beginning, but there's well documented differences in disease in women and men, and some potential issues around misdiagnoses and adverse events. One aspect that we haven't discussed in too much detail is around risk scoring, and one of the common elements around this in clinical risks is that females, except for CHA2DS2-VASc, are generally considered lower risk in many of the risk scores for development of cardiovascular risk in the future, and sex is treated as a binary classifier in that context, and that's something we'll come back to. So a lot of the work that I've been doing is around using artificial intelligence on ECGs to predict risk and detect disease. But one thing that was noticed some years ago now in 2019, which is quite interesting, but at the time not particularly that clinically helpful, was that you could actually estimate the patient's sex and also age, but in this context sex, pretty well with an area under the curve of 0.97 just from their 12-lead ECG. And we know from the figure on the far right that we've known for many years that there are elements that are helpful, like QRS duration, QT interval, that get us some way towards understanding the difference between sexes. But as you can see, when we take those parameters that we've known for a long time, we don't get anywhere near the accuracy that you get with the AI model, which is the ROC curve on the left with an AUC of 0.97. Our close collaborators in Brazil took elements of this concept, so using AI ECG predicted age, and saw that actually you could use this quite effectively to predict whether or not somebody would die early. So in this example, if your predicted age was significantly higher than your actual age, that means you were aging poorly, and that meant that you were higher risk of mortality in red. The converse was also true. If your predicted age was much lower than your actual age, that meant that you were aging healthily and therefore had a lower mortality in green here. And this is a concept that's existed, as mentioned, in other fields, in imaging and in brain. And this concept of this delta age or this age gap was an interesting one that we went on to look on further. So we initially extended this to look at what we call delta BMI or BMI gap. So here, looking at whether or not you can predict someone's BMI using the ECG, using AI. So again, the question might be, well, why not just ask their age or measure the BMI? But we found that if your AI BMI was greater than your real BMI, you had a greater risk of an adverse metabolic phenotype. So here, a greater risk of cardiometabolic disease or type 2 diabetes and many other things that are detailed in this paper. So, and separately to that, we developed this large platform of models that you could take AI ECGs from either signal or photos and predict a wide range of cardiovascular diseases and future cardiovascular diseases validated widely across the globe that potentially could be used for screening of cardiovascular disease. So the study that I'm going to talk to you about in most detail builds on some of these concepts to look at how we might use AI ECG predicted sex in something more clinically relevant. And so this builds on a lot of the work that I've discussed, where we took a large cohort of ECGs from Beth Israel in Boston, from about 1.2 million ECGs from about 200,000 patients. And we trained a convolutional neural network simply to identify if this person was male or female using just the ECG and nothing else. And as I've shown before, what we found is that you could do that with really very high accuracy. So an area under the curve of 0.94 in the Boston dataset and 0.97 in the UK Biobank for external validation. And you can see these histograms in green and red. So for males, green, females, red. And the vast majority of people were at the tails. So men were typically clustered around 0, which is what we use to represent men. And females clustered around 1, which is the number we use to represent females. But the part that was potentially interesting was this area in the middle where there was a minority of men and a minority of women that were being misclassified by the model. And the question was, well, what's special about these people? Is there anything different about them? And so to build on that, we developed the concept of this AI ECG sex discordance score, a bit of a mouthful, to build on the concepts I discussed before about delta age or age gap, which to calculate this, we took the patient's actual sex. So if you're a male, that would be 0. If you're female, that'd be 1. And we calculate the difference between that and your AI ECG predicted sex. So if your predicted sex was 0.7 and you were a man, the sex discordance score will be 0.7. If your score was 0.7 and you were female, then your sex discordance score would be 0.3. Hopefully that somewhat makes sense. So the further away from your predicted score, the further away from your actual sex, the greater your discordance score. And one really important element is that we found that the models predicted sex more accurately in more healthy and more normal cohorts. So this is a selection of different ways to slice the data sets. If you had a normal ECG, if you were an outpatient, or if you were relatively young, under 40, or if you were healthy as defined by an absence of various risk factors, then your performance measured by AUROC was greater. So the models were more easily identifying your sex. If you had risk factors or evidence of disease on your ECG, like a broad QRS complex, the models found it more difficult to differentiate between males and females on the ECG. And the reason why this is important, we'll come back to in a moment. So initially, when we looked at the whole cohort, so the derivation cohort was based in Boston, it was a hospital-based cohort, they were relatively sick patients. What we found was that the more discordant the score was, the greater the risk of adverse outcomes. Here is highlighted as cardiovascular mortality. And that applied to both men and women. But as I just described, it was more difficult for the models to identify sex if you had disease. And therefore, what we hypothesized was that actually this was a marker of people who had disease and not anything to do with the biological underpinnings of what we were looking at. So to separate that out, this is just one panel from the paper, but we looked at multiple different subselections of looking at populations that were more healthy. So that was healthier populations in the derivation cohort, so normal ECGs or outpatients, and also the UK Biobank, which as we know is broadly a more healthy cohort. And what we found here was that if you were male and you had a high sex discordance score, that had no impact on your cardiovascular mortality. But if you were female and you had a high sex discordance score, i.e. your ECG looked more male, then you had a higher risk of an adverse cardiovascular endpoint or cardiovascular mortality. So I won't go into too much detail, but we wanted to explore what this meant and why this might be the case. And basically the hypothesis based on this figure was that a female with a more male-looking ECG or a more male phenotype based on the ECG had a higher cardiovascular risk, but a male with a more female cardiovascular phenotype based on the ECG did not have any difference in their risk. So we explored that in more detail using a wealth of data, including the UK Biobank and the derivation cohort data using echocardiography. And first we looked at imaging associations. So basically, if you had if for females who had a negative correlation with a more male phenotype, they had a lower ejection fraction. So basically, if you flip that around, if you were more females who were more male had lower ejection fractions, and vice versa for chamber dimensions. We looked at this in more detail with various explainability analyses, which I won't go into too much detail on. But broadly, we found the models were identifying males versus females using some of the things that we've already discussed. So longer QT intervals, for example, were a more female trait. But by combining all those elements together, we could more accurately predict sex. We went into more detail with this in the UK Biobank, doing a phenome-wide association study. So on these plots, the positive above the x-axis is positive correlation, below the x-axis is negative correlation. So females who had a greater sex discordance score, i.e. were more male-like, had greater hand grip strength, greater bone area, greater whole body fat-free mass. So sort of non-cardiac phenotypes matching what we'd seen in the heart were sort of more male-like features, and also the associated increased risk of cardiovascular mortality. So this is quite interesting. So we then looked at what diseases were associated with this. So this is another type of PheWAS based on disease codes. Towards the top right, basically, is a greater incidence of the disease associated with a greater sex discordance score. So for females, if you had a greater sex discordance score, i.e. a more male type of ECG, you had kind of what we would expect from the previous figures, more cardiac disease, so more cardiomyopathy, more heart failure, more heart attacks, more cardiogenic shock. However, for men, interestingly, firstly, that was not seen. But also, we find, which we couldn't fully explain, we found a preponderance of liver-type disorders. And we hypothesized that perhaps that was something to do with sex hormone metabolism in the liver, and something that we think should be explored further, but we couldn't fully explain why this was the case. But the key point here is that you don't see the increased risk of cardiac disease that you see in the females that have discordant sex scores. And then Catherine built a really great pipeline for us to do genome-wide association studies in the UK Biobank. And we looked at if there was an association between the sex discordance score and common variants in females and males. And we found, again, there's very similar patterns. So females that had a greater sex discordance score had associations in genes that had associations to left ventricular mass, septal thickness, and sex hormones that may be potentially driving some of these phenotypes. So just to conclude our study here, we took 2 large cohorts from the US and the UK, looked at their ECGs, developed a sex classifier using AI applied to the ECGs, developed this sex discordance score, which is a difference between someone's true sex and their predicted sex, and then identified that females with a more male-like ECG phenotype identified higher cardiovascular risk, but that wasn't the converse for men. We looked at potentially why this might be the case, and we found that there was greater heart attacks and heart failure in females with a higher sex discordance, greater left ventricular mass and reduced ejection fraction, greater muscle mass, and less body fat. So we've described this novel biomarker that goes some way to exploring some of the phenotypic differences in females versus men. Thank you very much. Big thank you to our funders and the whole team. Take any questions.
Thank you, Aaron, again for a brilliant talk. So out of all your AI predictive work, right, I think I find this quite fascinating because, you know, you're basically what you're saying is that if you're more male on your ECG, you're more at risk. If you're more female at your ECG, you're less at risk. I mean, in summary, right? This is, and then what you're saying is that when you look at you know, why that is, it's to do with, you know, the body shape, also with the LV and, you know, the phenotypes that are well known from a long time ago. Mm-hmm. So the question is, are you actually detecting difference between male and female, or are you just actually detecting difference in cardiovascular risk factors like obesity and hypertension?
Yeah, it's a really good question. So we tried to address this. So one of the things, as Professor Castelli said, probably incompletely adjusted, but one of the things we adjusted for was body shape, body size, weight, etc. To try and address that. And some of that was part of the reviewers' comments. And similarly for the survival analysis, we adjusted for risk factors, so hypertension, hypercholesterolemia, etc. And in some of the analyses, they were in people that did not have any risk factors, again, trying to address that. And I suspect that the answer is twofold. One is probably that we are capturing some traditional risk that is perhaps incompletely measured at the point of the test. So people that have low grades of hypertension that are not clinical grade, or low grades of hyperlipidemia, small structural changes in their chamber dimensions or ejection fraction that do not meet clinical thresholds. I suspect that's a large part of it. But I do also think there is probably a sex-specific element. Otherwise, we wouldn't probably be seeing the unidirectional thing that we're seeing in this association. I can't fully explain it, but I think there's probably both elements.
That's great. And we've got a question there.
Thank you so much. It was very, very interesting. Have you looked at confounding due to drug treatment? So is it possible that your males or men are actually heavily medicated and therefore their mortality is not visible, whereas females are actually, their drug treatment, specifically with respect to cardiovascular related medications such as statins, etc., is different, and that is actually the causal or the explanatory factor behind the increase?
Yeah, thank you. Really good question. So we didn't look at that specifically. I think that probably is unlikely to explain all of the differences, because some of these cohorts that we looked at, for example, under 40s, it would be quite surprising if there was such a marked difference in medications in those groups. But I can't say that we addressed that specifically.
So just because we're quite behind, I'd like to conclude the first session and really thank Aaron for a wonderful talk and such an insightful piece of work.
Thank you.
We're going to break and come back from coffee at 3:45 rather than 3:40 to allow us time to just refresh. And in the meantime, I will be working very hard on changing my ECG from male to female. With Aaron.
That won't make a difference.
I'll see you at 3:45. Thank you very much.
Hi there, can you hear me? Sorry, one second, I couldn't hear you. Just give me a moment. Okay, I should be able to hear you now. Could you just speak for me, please? One second.
Do we still have some people outside? Okay, well, let's get started anyway. Welcome back, everyone, here and online for our second session, which I am sure will be as thought-provoking as the first one. And I'm going to open this session with our keynote speaker. I am thrilled to introduce Professor Heston den Ruiter, who is a professor of cardiovascular disease in women at the University Medical Center in Utrecht. She has done pioneering work that has spanned molecular biology, clinical science, epidemiology, and her work essentially has unraveled sex-specific biomarkers to help us bridge this major gap that we have in understanding and treating women's cardiovascular disease. Professor den Ruiter, if she is online, hi.
Yes,
it's great
I'm here.
to see you, even if it is online. And please take it away whenever you're ready, if you can share your screen.
Yeah, thank you for inviting me to this wonderful event. Maybe good for the audience to know that I was actually on a train when I heard that my flight to London got cancelled, and they put me on some ridiculous flight to Luxembourg and then to London. So I just wasn't in the stars to be there today, but I'm happy that nowadays we can do these type of presentations also online. So I hope I get to meet you all sometime soon. Let me share my screen. Let me see if this works out. Can you see my screen?
We can see your slides, yes.
Ah, perfect. Yeah, so I always like to start with this very optimistic picture on how fantastic heart disease over time has gone down due to the phenomenal innovations in cardiology and also beyond cardiology. So let me get my pointer. So what you see here is a timeline from the 1950s until, let's say, 10 years ago. And these high lines are a combination of cardiovascular diseases in men, in women, and then these dotted lines are coronary heart disease, and these are the stroke death rates per 100,000 people. And this data is from the United States, and you can clearly see that the recording of coronary heart disease became common among the 1970s. And as you know, this trend has been going down, which is fantastic, but the downside of it is that we have more people living with cardiovascular disease because they, of course, survive it. And nowadays, we're sort of into equal numbers of women and men dying in our population from the majority of cardiovascular diseases, but women are overall a bit older when they die from cardiovascular disease. And one of the main striking observations was that women seem to more often have a missed diagnosis of myocardial infarction. And these are two studies in the region of the Netherlands where they actually asked the population to participate in research, and these people had a questionnaire and a EKG. And here in red, you can see the pathological Q wave. And these people were asked, were you ever familiar with having a myocardial infarction? So having this pathological Q wave as a sign of having had a myocardial infarction with a negative questionnaire meant that the myocardial infarction must have been missed. And that is actually quite common. So what you see is approximately over the different age ranges here in the left in men, that approximately 1 in 3 of these myocardial infarction goes unnoticed. But in women, although the incidence is lower, so the absolute numbers of myocardial infarctions were lower, there seemed to be a larger prevalence of these missed diagnoses of myocardial infarction. And as you know, there has been a lot of awareness on potential different symptoms that women may have. And I think Professor Rasha Al-Lameh also explained that this may not always be the case. But if you look at the summary of the scientific evidence, the major complaint of a myocardial infarction is chest pain in both women and men. Women just tend to also report many other symptoms that may distract from the chest pain. So I think in the clinical arena, this is quite common, but what my team over the years has been working on is more on actually the pathophysiology underlying heart diseases. And it was super exciting to hear Professor Aloki Finn talk about SCAT, so I don't need to say anything about that anymore. And then Professor El Lamé on the ANOCA population, so the non-obstructive diseases where diagnosis of spasm and microvascular dysfunction have been discussed. And today I'll talk to you a bit more on the classical cause of myocardial infarctions being severe atherosclerotic disease. But before we dive into that, I'd like to show you this picture where it's unpublished data submitted, where here we plotted the publications per year, a 5-year average. It's a log scale, so these are huge numbers of publications. And it's really cool to see that from the 1950s onwards with the registrations that also are research on heart failure, mostly reduced ejection fraction, and coronary artery disease, mostly focused on plaque rupture phenomenon, skyrocketed in those years. However, if you look at what you see here, SCAT, and this ANOCA population, it becomes evident that it's not only the evidence base that is much lower, but the research into these phenomena came much later. And this is actually fantastic work, pathology work from the group of Renu Vermani from CV Path, who defined plaque phenotypes that were underlying myocardial infarction in sudden death cases. And what their group has shown, and we have shown it in other vascular beds, is that there are specific plaque phenotypes that have sex-specific differences. So what you see here on the left side is a coronary plaque with a huge necrotic core here. And here you see this red, this is the thin fibrous cap, but it has been broken through because there's this red staining on both sides. And this is the typical plaque rupture that we see, which is very common among men with an acute myocardial infarction. They also showed that plaque erosion, so here you see that the cap is actually still intact, so there's a thrombus that's actually sitting on the atherosclerotic plaque, so the outcome is an occluded vessel, but there seems to be a different mechanistic underpinning in this plaque. And we have also shown that indeed, if you look at male and female plaques, that we can clearly see that the female plaques are more fibrous, more stable, more smooth muscle cell and collagen-like, whereas the plaques in men are more inflammatory, have larger lipid pools and more intraplaque hemorrhages. So we started out years ago with trying to unravel what are actually the molecular drivers that make this plaque more towards plaque rupture, and what does the plaque move more towards plaque erosion that we see more common in women. And I'm taking a very little time here to explain to you what we did. So this is a very simple graph on gene expression. So here you have one gene, two genes, gene 9 and gene 11. And what you can actually do is not only look at the gene expression, but also how these genes behave together. So their co-expression. So for example, here, this red line, you see that this gene with this gene has a very strong correlation. So they're very co-expressed together. And I always tell my students that you can think about co-expression networks as schools, where you have different classrooms with kids, and one class sort of behaves the same. They go for lunch together, and so they're the same people, and they're very connected in their behavior. And that's also how we see that in the biology. So a higher connectivity, so more co-expression within genes indicates that these genes are highly likely to be more functional for biology. So in our first studies working together with Karolinska Institute, who had also a large biobank of plaques from patients with severe coronary artery disease, we looked at these gene connectivity patterns within the atherosclerotic plaque. And I'll explain it to you. So what we did, so these are the 5,000 genes that were expressed within atherosclerotic plaques and there were a bunch of 500 plaques that we studied, and approximately, I'm sorry, I'm mistaken now. We took out all the plaques from the biobank, and we made a sample where we did exactly the same, selected exactly the same number of male plaques and female plaques. So we looked at the gene connectivity in a sample where we only looked at the male plaques. And there you see all these lines indicate where these genes are actually co-expressed. And then from the 160 male plaques, we did an analysis with 159 and then added one female plaque, and 158 added two female plaques. So on this x-axis, we move from 100% male plaques to 100% female plaques. And what you can actually very nicely see is that the gene connectivity actually shifts. So if you would do, as we always did in cardiovascular research, study a sample, a biological sample of 70% males and 30% females, that really looks like the sample of 100% males. But then if you move to this 100% female samples, you see these darker connectivity lines popping up, which actually tells us that we should look at this independently, because it's very likely that the biology within this part is very different from the biology that we see in the upper right corner. So from that moment onward, we had a focus on the female plaque. So we identified 3 large gene networks within the female plaque. So all these dots are different genes that have a strong co-expression. And we identified that in the female plaques, we found networks that were mostly expressed by endothelial cells, smooth muscle cells here in blue. This was a huge network. And here a network that was mostly expressed in macrophages. And here you see that some of these networks point to cell transition, but also estrogen response. And I'd like to note here that these women are 68 years on average. So with our Leduc network, Atherogen, that we got funded in 2022 with a group of researchers, we identified that the female plaque has a very active cell transitioning state. So we identified that female plaques are specifically strong in endothelial to mesenchymal transition. So the endothelial cell goes through an intermediate state into a mesenchymal-like cell. And similar to smooth muscle cell, this blue network pointed to the smooth muscle cell transforming into a myofibroblast. So this was really clear, and we had talked about it a lot, and everyone asked us, well, then how do you differentiate between what is plaque and what is female specific, because they're so intertwined? So we asked ourselves the question whether if you would look at one specific plaque phenotype, let's say the female phenotype that is very fibrous, would we find sex differences in the molecular regulation if these plaques on eyeballing in histology would look exactly the same? And that is what we studied. So we took our ATRO-Express biobank. These are carotid and arterectomy samples from patients who underwent the surgery We take them from the lab, and we process it for histology, but also for RNA sequencing and also single-cell RNA sequencing. We also have a very nice collaboration with Professor Meyer, who's I think now in the room there, for proteomics of the plaques that we did. And here you see a nice example of a huge plaque that we took out of a patient. So this is the typical plaque that we see. This is a fibrous plaque, nicely homogeneous, rich in smooth muscle cells and collagen. And then if we look at the proportion of these plaques in our female and male patients, we see that the females actually have a larger proportion of fibrous plaques. That is something that we knew, but it was still nice to see it again. So about half of the plaques in women are fibrous, and about 1/3 for the male plaques in our biobank. And we then investigated the risk factors. So among the fibrous plaques, we saw that women had a higher were more often smokers compared to the males that presented with fibrous plaques. And this was not the case for the atheromatous plaques. And conversely, interestingly, we saw that males with fibrous plaques more often presented with diabetes compared to females with fibrous plaques. And we also did not see that with the atheromatous plaques. So we looked at RNA and proteins, so in the plaque. And what we observed here above, so on this plot on the right side, you see genes that were higher in the male fibrous plaques compared to the female fibrous plaques, and here on the left, the genes that were higher in the females. So what we saw in pathway analysis, and we also did it in a matched samples where we propensity matched for the risk factors, we identified that female fibrous plaques have a strong signal for collagen, extracellular matrix organization, whereas if we look at the male fibrous plaques, we actually see more of the immune response and inflammatory signal. And this was actually lost in the propensity matched analysis, meaning that very likely in these men, the higher prevalence of diabetes explained this more inflammatory signal. In the proteomics, which is of course another layer of molecular biology, we identified that in the women we find TGF-beta being highly strongly expressed in the plaque, as well as endoglin, so all proteins within the TGF-beta pathway. And also here in the male fibrous plaques, we saw a strong signal for immunity and immune mediated processes. Then we worked with Professor Maagdenvassel from Munich with the Munich Vascular Biobank and asked him if we could together look at where the genes that were active in the male fibrous plaques versus the female fibrous plaques, where they actually were located in these plaques. So here you see the H&E staining and the macrophage staining. And this is the spatial data where you can actually see the highlighted genes from the female. So this is where the female fibrous genes are expressed. And it's clear that this is mostly in the fibrous cap and in the media, whereas the male fibrous genes were mostly located close to the CD68 positive macrophage clusters. This was quite remarkable because we then hypothesized that maybe these fibrous plaques in males and females must be related to different cell types. And this is our single-cell RNA sequencing data. So we identify approximately 13 different cell types within our atherosclerotic plaques. And here you see them in the graph. So here we have smooth muscle cells, two types of endothelial cells, the inflammatory cells, T cells, B cells, and mast cells. And what was quite clear for both the fibrous genes and the proteins, that in the females, indeed, most of the genes are expressed in either smooth muscle cells or endothelial cells. Whereas in the male genes, we actually see here in green that these genes are mostly expressed by macrophages and inflammatory macrophages. And we also saw that using a deconvolution technique where you actually use the single cell data to infer where these gene expression patterns in the plaques are coming from. And this also showed that indeed the female genes are more pointing to smooth muscle cells and endothelial cells, and the male genes more to macrophages. We then, because the TGF-beta signal in the female fibrous genes was quite strong, we then went to look at endothelial to mesenchymal transition, which is in endothelial cells a very strong pathway. So here you see, and this is from our previous work, where we actually defined intermediate endothelial to mesenchymal states. So these are the single cell lineages where we actually here see the transition from the endothelial cells to the smooth muscle cells. And from the female fibrous genes, approximately half was an endothelial to mesenchymal intermediate marker, suggesting that a lot of these female fibrous genes are pointing to this endothelial to mesenchymal transition. And we did not see this in the male fibrous plaques. We wanted to see whether this was cause or consequence. So we wanted to see whether upon TGF-beta stimulation, if indeed the female genes that we observed in the plaques were upregulated, and for that we used our primary endothelial cell culture. So with the same procedure, we take the plaque out of the patient. It's so simple, and then we take a cotton swab and we swab the luminal side of the plaque, and we culture this. And we have published that this is actually a good method to get primary endothelial cells from these patients. And we expose them to TGF-beta in this protocol that we have established before. So what we see, which was really nice, we see the endothelial markers going down upon TGF-beta stimulation as expected, the mesenchymal markers going up, and at the same time, indeed, we could find that our female candidate genes from our plaques were indeed also responsive to TGF-beta. And here you see our last experiment where we added CIS3, which is a SMAD3 blocker, into the cell culture to see if we could partially mitigate the effect of TGF-beta, which was partly true, which indicates that it is likely via the SMAD pathway. So from this study, we conclude that end-stage fibrous plaques exhibit sex-specific clinical and molecular profiles. And this suggests that women and men may develop the plaque pathology through distinct cellular and molecular pathways that may be important for our drug development pipelines over the next years. And with that, I'd like to thank my team who have done the work, but also my collaborators at UCLA, especially Mette Civilek, Newcastle University, Stephen White, Lars Maagdevessel from Munich, Virginia, and also Manuel for the collaboration on the proteomics, and from Berlin, Denitsa Mateva. And with that, I'm happy to take questions. Thank you.
Thank you very much, and we do hope to see you in person soon.
Yes.
Questions in the room? And is there a roaming microphone going around? If there's any questions? Well, I'll start with one. I was wondering if I could ask, I find it fascinating that there is this, this molecular fibrous accumulation in females, this indication. Do you think that is it associated in any way with something like I don't know, preeclampsia, for example, where we've got this endoglin phenotype and it's a cardiovascular disease, and maybe long-term it might associate with a more fibrous phenotype in some women, maybe?
Yeah, a very relevant question. I don't know about the molecular biology, but we did do a CT plaque morphology study in women that were 20 years after preeclampsia to see, and about half of these women develop asymptomatic plaques when they're around 50, so approximately 20 years after preeclampsia. And we also see that they often have these typical fibrous, let's say non-atheromatous plaques when we looked at it with software imaging. So it does seem to be a sort of a female predisposition to this fibrotic pathway. We also, I think what was shown for the SCAT samples also points to this collagen issues, as well as TGF-beta, if I remember well from the presentation from Professor Aloka Finn. I think it was a TGF-beta genetic variant that he highlighted. You see it in different diseases, also with microvascular disease conditions that affect women more often than men. We seem to have this pathway involved.
Yes, absolutely. And diseases like scleroderma, for example, where this pathway is obviously very predominant and a female predisposed disease. Any questions in the room? Prof. Casadei.
Thank you very much. Very lovely lecture. I was wondering whether there is a difference in the cellularity of plaques between men and women, you know, the actual number of cells, and whether that can influence your subsequent analysis.
Yeah, so it's very difficult to disentangle, let's say, the cell composition from sex because it's so intertwined. We try to do it by histologically looking at sort of the same plaques. And then still, even though they were sort of by a pathologist quantified as fibrous, we still see that women have more smooth muscle cells, more endothelial cell involvement within this plaque. So we think it's very likely that this is, of course, an accumulation of years. These plaques are, coming to life for decades. So we definitely cannot exclude that this is also a cell composition phenomenon that we're looking at.
Thank you very much.
One final question. Thank you.
Thank you. Thank you so much. I really enjoyed it as well.
Okay, I think we're all good now.
I just wanted to add, I really enjoyed you saying or mentioning the gene connectivity and how these genes that come together often behave together. But we often in epidemiology and statistics see this as a problem. We call it multicollinearity because it interferes with us trying to identify the target, the actual thing that we should be going after. So I was just curious about your views on that.
Yeah, we have analysis where we identify key driver genes. So if you bioinformatically would knock out one gene, you can predict what happens to the full network because there's a hierarchy in these genes. One thing we have done is identify a couple of these genes and then knock them out in vitro and see how they affect the gene regulation of the full network. And then you see what probably also you see in epidemiology, that there are sort of key regulators that are more important and they sort of define, or they're more important for the network rather than some genes that seem to be innocent bystanders. So there are different techniques on how we have identified key driver genes that are more instrumental to these networks than others.
Thank you very much. We are delighted for your talk, and we hope to see you in person soon
Yes, yes. I'm so sorry for not being there live. It was. I hope I get a chance to see you sometime soon.
Thank you. Everyone, a round of applause, please, for our keynote speaker.
Bye.
Okay, so moving swiftly on to our second speaker, we have Dr. Martina Rudnicki from UCL. She is a research fellow based at the Institute of Ophthalmology. She's a pharmacist by training, but she has been studying angiogenesis for the past few years, and she has a major interest in understanding how cardiometabolic regulation may modulate these disease phenotypes. So I will let you get on. Thank you.
Thank you. Thank you so much for the kind invitation and also for the kind introduction. I'm going to switch gears slightly because now I'm going to present some data that they are coming from mouse work. We have been discussing mostly patients and human samples, but I'm also going to present now how we can actually support this understanding of sex differences. And I'm going to share with you some of our data on sex differences in adipose endothelial cells, because we have plenty endothelial cells in our body, but they are not the same. Then I'm going to focusing on the population that we can find in adipose tissue. This tissue, it's very highly dynamic. Depending on the calorie availability, it can expand or shrink. But there is also other situations when we have adipose tissue expansion, that it's during development, when we are growing, our adipose tissue expand. After injury, we also have some expansion of adipose tissue, and during pregnancy. And although we think about adipocytes when we talk about adipose tissue, this tissue is composed by several other endothelials, other cells, and we have one type of cells, that is the endothelial cells that they are pointing there. I'm trying to find a pointer here. I'm not sure. Is this also? No? Okay. Okay. Then we also have a population of cells that they are endothelial cells there. And endothelial cells, they are numerous cells, as I mentioned, we have in our body. They line the inner layer of all our blood and lymphatic vessels. Then they have these beautiful structures, as you see in this staining. We have capillaries in the adipose tissue. They supply nutrients and oxygen for all the cells. They also regulate immune cell trafficking. Then they're very important in our inflammatory states. But they have another role, one that is very important. They coordinate the vascular remodeling or the growth of more vessels through a process that we know as angiogenesis. So when you have an expansion of a tissue, in this particular case, the adipose tissue, if you have expansion of your vasculature, your local vasculature, we know this expansion is going to be healthy. But what we see when a mouse is exposed to a high-fat diet is that we have the vascular density locally, it's actually reduced. Then you have less vessels compared to a lean mouse. An obese mouse is going to have less vessel there. And as a consequence, when you don't have angiogenesis happening, then you have less capillaries, you will have points of hypoxia in your tissue. You are going to also have inflammation, fibrosis, necrosis. And although this data comes mainly from animal studies, single-cell data from patients are validating that this is actually happening in human samples as well. We have less endothelial cells with an angiogenic profile. Then the endothelial cell seems to lose the capacity to actually develop and then have more vessels growing during this time. Another point that is important to mention, animal work mainly use male mice. historically, we have this conception that if we actually include female mice in our studies, we are going to have more heterogeneous data. But this is not the case. And then because this data was coming from male mice, and we know that male and females, they actually showed sex differences in obesity pathogenesis, some years ago, we asked if we could see the same, that the vasculature will be reduced in adipose tissue. So we exposed males and female mice for a long period of diet, 16 weeks of high-fat diet, and we assessed the adipose tissue, mainly the one in your visceral cavity, that it's the one that is harmful for the obesity pathogenesis. And what we saw, it is that females actually have greater vascularity compared to males when they are exposed to a high-fat diet. But because female mice don't actually gain as much weight when they are exposed to a high-fat diet, we are challenged to actually explain this data, if maybe this was the cause or the consequence of gaining less weight. And we have another cohort of mice where we have some females that they were older to actually have similar weight as the males, and then we expose them to the same period of diet, high-fat diet, and we saw exactly the same result. We have greater vascularity in female adipose tissue compared to males. We look further to understand if the difference was on the molecular mechanisms, and then we analyze, proceed with some transcriptional analysis, but because we are interested in what will be driving the phenotype, we expose the mice for a shorter period of time, 7 weeks, and then we isolate endothelial cells from the adipose tissue, and we actually proceed with bulk RNA sequencing. When we first looked at the data, we saw that more than 1,000 genes were different between males and females. And for our surprise, they actually are distributed across different chromosomes. They are not coming from sex chromosomes here. Then we analyze also the gene ontologies that for the process that could be justifying why we have differences in angiogenesis between male and females. And if you look at the bottom, you will see that the signature that is related to males, it's telling us that they acquire some pro-inflammatory response. Then the male endothelial cells have more inflammation there, or more genes related to inflammation. On the other side, we have the females with different gene ontologies that they are all related to replication and transcription. As we know that when we have the RNA sequencing data, this is actually indicating some genes that can be important, but we have to validate this is indeed happening. Then we isolate some endothelial cells from healthy mice, males and females, and we actually cultivate them for a period of time, exposing them to TNF-alpha. And for what we actually saw, it is that the males, they respond they have a greater response to TNF-alpha. As you can see, have greater mRNA levels of ICAM and CCL6. But we also have some basal pro-inflammatory genes being higher in male endothelial cells, as you see on the other two genes that they are on your left. For validating what we saw in the RNA sequencing for females, we had again another cohort of mice. And we have indication that we have more proliferation of endothelial cells in the adipose tissue. So we expose again the male and females to a high-fat diet, again 7 weeks of high-fat diet, and then we actually administer one reagent that can give us an idea if we have more or less proliferation, that it's EDU. when we analyzed the adipose tissue, we could see proliferation happening in both sexes. It's not that the male endothelial cells are not proliferating, but they are proliferating less. Then when we count all the cells that we can see that they are in a proliferative state in the adipose tissue of males and females, we have more cells actually proliferating from the females compared to males. And this was the same result if we actually cultivate the cells in vitro, then we expose them to growth factors, and we could see greater proliferation in female endothelial cells compared to males. We also ask if this was because of the environment that they have. Well, the in vitro assay that I just showed you, it was indicated probably not, but when we assess the levels of some growth factors that we have in the adipose tissue, we also see no difference at all. So what exactly is happening, and how can we understand that will be the underlying molecular mechanism behind these differences in endothelial cells? When we have studies that they are preclinical studies using mice, one of the main directions that they take, it is that they overectomize females, and then they castrated males, and then they try to understand if these differences are coming from hormonal levels. But then we did something differently. We are actually making the use of one mouse model that the male carries 2 mutations. We have then one gene, the SLY, and it's the only gene that it's important actually for the development of the testes. Then if you exclude the SLY from your Y chromosome, then you don't have the development of testes. But for having a healthy male, we also have a second mutation that it's introducing again, this gene, but in an autosome, not in a sex chromosome. And when you cross this male with a normal female, then you will have 4 different possibilities. The first 2, you have a male carrying these 2 mutations and developing the testes. You are going to have a female that carry no mutation at all and develop the ovaries. But you're also going to have a male that is going to have XX chromosomes, but because you have the gene that is the SLY in an autosome, it's going to develop the testes. And you have a female that is an XY female, because there is no SLY gene in the Y chromosome, then it was going to develop ovaries. Phenotypically, they look the same as another female that is going to be an XX female. About the hormone levels, this is a really established model, and they don't have a difference as a normal or typical male and a typical female. Then this model can help us to understand if the difference is coming from sex hormones or sex chromosomes, because you have all the different combinations here, and you can try to understand what will be the cause of your differences. So we exposed these mice to a high-fat diet, now for 12, 13 weeks of high-fat diet, and we again analyzed the adipose tissue to try to see in what direction we need to take this work forward. Again, we have the validation of our previous work when we have less vascularity in the adipose tissue of the males versus females. And we also think about that mainly these differences are coming from hormones. Then first, we analyze the male that is XX male. And as you can see, actually has a bit more of the vascular density compared to a male in your left XY, but it's not significantly different. And also it's not different as a normal female. But for our surprise, when we have a female this XY, then we have less vascular density compared to a female that is XX, pointing out that although we would speculate that the differences in vascular density is coming from hormones. Maybe it's not the case. This work is actually ongoing, and our RNA sequencing is also we are trying to understand what pathways we need to focusing on. So in summary, I hope that I can convince you that having both sexes is important when you are actually in preclinical studies developing them. And in response to high-fat diet, we know that male endothelial cells acquire a pro-inflammatory phenotype. I forgot to mention that this is also seen in human patients. We have a collaboration with Professor Joanna Kaluka that sees the same in human samples. In response to high-fat diet, the female endothelial cells keep this proliferative state, and then the adipose tissue is going to be healthier. We also see that the sex differences cannot explain the resilience of the female endothelial cells. And we are actually trying to understand if sex chromosomes can indeed explain fully or partially these sex differences in endothelial cells from the adipose tissue. So I would like to thank all the people involved in these studies that we have been developing. Also, I'd like to thank the funders for enabling this work to be done. And also, I'd like to thank your attention. Thank you.
Thank you very much, Martina. That was great. Very, very exciting. Questions in the room? Anyone? I will ask you. Oh, Daria, you go. You can take my question.
Thanks, Martina. I was wondering if in your in vitro studies you've tried to incorporate charcoal-stripped serum, which removes sex hormones from serum that might still have some effect on sex differences that you're observing.
We did. We still see the same. Yes.
Thanks.
Thank you very much. In the interest of time, I think we'll move on, but maybe at drinks afterwards, if any questions, please go to Martina. Another round of applause for Martina, please. Thank you. Now, it is my absolute pleasure to introduce Professor Manuel Meyer, who is the head of vascular science and the original home of the Vascular Network. He's going to give us just a small insight into the fantastic work that he does on cardiovascular disease using all these beautiful platforms that he has. Please take it away, Professor Meyer.
Oh, thank you very much. It's a pleasure to be here, and the platform is very simple. It's proteomics. So the title is His Plug, Her Plug, Can Proteomics Reveal Sex Differences in Human Atherosclerosis? So why proteomics? You have heard a lot about transcriptomics and histology, but we all know that there's concordance and discordance between the transcript level and the protein level. We have 20,000 protein-coding genes, but probably 1 million protein isoforms. And this is due to post-translational modifications, so clearly complexity doesn't end at the RNA level. This is an example from fresh frozen coronary arteries, human coronary arteries, 150. We did bulk transcriptomics and proteomics on the same sample. And on the x-axis, you've got the matrix proteins. On the y-axis, you've got the correlation. And yes, indeed, there is a correlation. 25% of the proteins do show a significant correlation to their transcript levels, but the maximum correlation is 0.5. And this is expected because, of course, proteins accumulate over time. So RNA expression is only a snapshot of gene expression at a single time point, while proteins obviously accumulate. And if you analyze tissue, you should also look at the protein level. The challenge in proteomics, of course, was that we didn't have the same large cohorts like the transcriptomic studies, and this was a review we wrote 5 years ago. And this was, again, looking at proteomic studies in human carotid endarterectomies, and you can see the sample size was indeed very small, including our study that was published in JCI in 2017. And the way we got around this was, again, combining proteomics with transcriptomics. You have heard about the Karolinska Biobank before. They again did bulk transcriptomics on carotid plaques. We added proteomics data on an independent cohort and looked for combined signatures of symptomatic plaques. And this signature was very much driven by neutrophil proteins such as MMP9, S100A8, and A9, which is calprotectin. So neutrophils in plaques are associated with symptomatic plaques. But then, of course, we have the Foundation Leduc, which is a fantastic organization because it brings together groups across Europe and the US. And we had a consortium called Placomics, which allowed us to collaborate with these institutions. And what we did was actually a study that I think is unprecedented to date. We did proteomics on carotid endarterectomies, but in the hundreds. And we had about 200 samples from a discovery cohort from Austria. And then you've heard about the Astro Express cohort, another 200 samples as a validation cohort. We then used clustering to use the proteomics data to identify patient groups that are at risk. And in our discovery cohort, we had 9 years of follow-up data on the same patients. And what we could see is that the clustering of the patient groups is partially based on sex. So you can see here the red Kaplan-Meier curve in particular basically has 0% females, these are all men, and they have a dismal outcome. So we very much should study women in order to help men, because actually women do much better than men. So what are the differences? If we look at the patients that were predominantly plaques from male patients, we get two distinct survival curves. Cluster 2, as I told you before, more than half of them actually have another event within 9 years. Cluster 1 does significantly better. What's the difference at the proteomic level? Well, first of all, male plaques have more inflammation, and again, you can see here this neutrophil signature that I mentioned before, S100A98. You've got myeloperoxidase, red means an upregulation. So both of these groups had a similar degree of inflammation. Inflammation at the time of the carotid endarterectomy did not determine long-term outcome. What determined poor prognosis was the loss of the matrix-producing cells. If you have an inflamed plaque, but you still have matrix-producing cells, you have a better survival compared to actually plaques that have lost the matrix-producing cells. Women, with regards to their prognosis, were in between the two curves I've just shown you before, which were predominantly from male patients. They had, in general, less inflammation, so less neutrophils at the time of the surgery, less inflammatory signature. This is why these dots are blue, so this means a downregulation compared to male plaques. But surprisingly, if we look at calcification, calcification in women wasn't associated with a better prognosis. In fact, both of these curves look very similar. In fact, the plaques that were calcified in women actually were indicative of a slightly worse prognosis over the subsequent 9 years. And this is very much in line with this particular study from the Coronary Artery Calcium Consortium, where they looked at sex differences in calcified plaques and long-term cardiovascular mortality. And the take-home message was that for a given degree of calcification, women actually seem to have a worse prognosis compared to men. So what determines calcification in plaques? So we can look at proteomic signatures. I've told you about the inflammation signature, which is very much dominated by neutrophils in the plaques. Ultrasound signature mainly correlates to the collagen content of the plaque. But the calcification signature is determined by different proteins, and two of them are very important, and these are called large aggregating proteoglycans. This is an image of one of those large aggregating proteoglycans. It's called aggrecan. You're all familiar with aggrecan. It's the main proteoglycan in cartilage. In vessels, you usually do not have aggrecan. You have got versican. But actually, if you apply compression to a tissue, then you induce the proteoglycans, and you can induce both aggrecan and versican in the vessel wall. So this was seen when we did a study in pigs, where we actually looked at stented coronary arteries. And again, you induce tissue injury, you get the loss of smooth muscle cells. The remaining smooth muscle cells then deposit large aggregating proteoglycans. They are space-filling proteoglycans. They first deposit versican, and afterwards they deposit aggrecan, which basically marks the transformation to a more cartilage-like stage. And again, the same is seen in human calcific aortic valve disease. Here we can actually take from the same valve the non-calcified and the calcified region. And again, you see this characteristic shift. When the fibrotic calcified valves, you get more aggrecan, whereas if you've only got fibrosis, you get predominantly versican. And these are distinct cell populations, like Hester has said before. So the valve interstitial cells that produce versican are periostin positive, and the valve interstitial cells that deposit aggrecan are osteopontin positive. So you have a transformation to a cartilage-like matrix, and you see this in different diseases, not just in atherosclerosis, but also in calcific aortic valve disease. But I think this was really, the main output over many months, because of course this was a huge undertaking. The discovery cohort in red, the validation cohort in light blue, and first of all, look at the consistency. These are two independent cohorts. They've been run months apart. This is looking for female versus male differences. You've got two clusters of matrix proteins that determine differences between plaques from female and male patients. One cluster contains versican, the other cluster contains aggrecan. And for those of you familiar with matrix biology, you also see many proteins that regulate TGF-beta signaling. This is what Hester has been talking about before. And of course, this is not just important for plaques, this is also important for other diseases. You've heard about Aloke Finn's talk about SCAD, which is predominantly a disease found in women. And we are fortunate that we have another Leduc consortium now looking at matrix in fibromuscular dysplasia, where again, looking at human disease together with genetics may hopefully unravel where certain diseases are more predominantly found in women compared to men. And with this, I'd like to end. So the plaque proteomic study has revealed sex-specific changes. These were predominantly changes in matrix. Advanced plaques show sex-specific extracellular matrix remodeling. In women, we tend to get less inflammation. We get more proteoglycan accumulation. And this versican to aggrecan transition is associated with a cartilage-like matrix state, which may explain why we see more calcification in women compared to men. And of course, this is a huge team effort. First of all, I need to thank the Foundation Leduc, otherwise these studies would not have happened, and our collaborators again at the University of Utrecht for the Athero Express study, and at the Medical University of Vienna for the discovery cohort. Thank you very much for your attention.
Thank you very much. First we'll go to Anna and then to Ramsey, please.
Thanks, Manuel. I was really struck by the fact that both you and Hester have seem to have identified this higher inflammation in male plaques in different, partly overlapping database and so on. So I guess my question is, at the heart of what this meeting is all about, how can we, and perhaps it is also for Ramsey, how can you, at this stage of our knowledge, somehow start to link the pathology with the clinic? So is it that a more inflamed plaque, as one finds in men, gives a different type of clinical picture? A broad, very broad question. Any thoughts?
Well, also this is the largest proteomic study to date. We are still talking hundreds and not thousands, so I think we need to take this with a pinch of salt. But what I was really finding striking is that both male plaques that had a high degree of inflammation were associated with very different outcome in prognosis. So actually, it matters whether you have matrix-producing cells, you have inflammation, but as long as you keep your matrix-producing cells that protect the plaque, you may have less events. And I'm wondering, as much as inflammation is important, we shouldn't forget about the matrix-producing cells, because if the inflammation is contained, the outcomes are actually better. And again, in women, these plaques at these advanced stages are not inflamed anymore. Of course, we only get the end stage, so we do not know the trajectory. It could have been that, of course, these women were progressing faster. I mean, they were age-matched. Both of these cohorts were 70 years of age. And of course, we do know that women develop atherosclerosis later than men. So if you have, at the age of 70, the same degree of stenosis, it could also mean that you have been progressing faster compared to your male counterparts. So what we are maybe seeing is that these are women who had a very fast progression after the menopause and caught up in terms of the plaque pathology compared to male, whereas in men, we still have this lipid-loaded inflammatory plaque. So this, of course, the downside of doing human studies, we do not get multiple time points when we take those samples.
So thanks, Manuel. Really excellent data, and obviously with the previous speakers in concert. At the risk of promoting another meeting, we're going to spend 3 days discussing plaque characteristics that convey risk at the Imperial Vulnerable Plaque meeting, 12th to 14th of September, free online for everyone to attend. So, this will be discussed in greater detail. Manuel will be there. The kind of, the whole, I'm actually getting some palpitations looking at you because we're just designing experiments, doing passive immunization with antioxidized LDL antibodies. And it's interesting because we've not really thought about, sex differences, etc. But almost certainly in women, plaque erosion and vulnerable plaque due to other characteristics than a highly inflamed plaque with a thin fibrous cap is becoming more and more obvious. And even though the prevalence is less at an older age, it still does happen. And, we've got to work on figuring out the different pathologies. The question is, in translational clinical medicine, does this mean that our clinical trials using anti-IL-6 and possibly anti-IL-1 will work better in patients who are male rather than female? And it might be that, kind of in a very different way to statins, looking at the data from you and Hester, that might be something that might come up. I am not aware from the Cantos study whether there were sex differences, and I'll have to look more carefully at the anti-IL-6 data. But what do you think? Have you looked at that at all? Or?
Well, I think we need to figure out what is the residual inflammatory risk, and what is the residual inflammatory risk in the vessel wall. Because at the moment we target the main highways of inflammation. We go after interleukin-1 and interleukin-6. Of course, this is a mark of systemic inflammation, but are we actually targeting vascular inflammation, and what mediates vascular inflammation? So I think this is, for me, a bit of a more important question. What is the difference between systemic inflammation and local vascular inflammation? And going back to your erosion question, Renu Vermani's work very early on showed that erosion was linked to proteoglycan buildup. Right? Again, what we see in the plaques, more proteoglycans, predominantly in women. So this would also link nicely to what Renu Vermani showed many years ago. With histology, that it's not the collagen content that differs, it's the proteoglycan content that predisposes vessels to erosions. Because you build up the proteoglycans in the subintimal space, and that, of course, then can dislocate the endothelial cells. And the same is also seen in aneurysms. In aneurysms, you get proteoglycans building up between the smooth muscle cells, and you start rupturing the elastic fibers. So yes, we have reduced matrix mainly to collagens, but the proteoglycans, because they're important for tissue swelling, and they seem to be dependent in part on sex hormones, that may explain some of the differences we see in vascular pathology.
Thank you very much. Let's go one final question to Daria, if you don't mind. Sorry, she raised her hand before you, and then...
Sorry, I just wanted to answer Ramzi's question about anti-IL-6 drugs. So there is a paper which Haris shared with me a year ago about rheumatoid arthritis, showing that tocilizumab works better in males than in females.
Yeah.
So it might be that there are some shared mechanisms between different diseases.
Although tocilizumab is a very interesting anti-IL-6 because it actually increases your lipids. So it's even more interesting that it shows better success in males for that reason. Thank you very much, Manuel. Thank you. And I am delighted to welcome our final speaker, Dr. Daria Gostiunina, who is a research fellow here in the vascular science section and one of our organizers for today. Daria works on sex differences, trying to understand how sex differences shape vascular function. And today she's going to give us an insight in the pulmonary vasculature and how that relates to sex differences. Thank you, Daria.
Thank you very much, Haris. Thank you for your kind introduction. I'll be talking today mainly about sex differences in pulmonary endothelial cells. And I'm looking at how biological sex, which is sex chromosomes and sex hormones, shape vascular function and dysfunction in health and disease. I use a range of different techniques at the moment, mainly focusing on organ-on-a-chip, transcriptomics, and proteomics approaches. And I'm also involved in community work, serving as a co-lead of the Women's Health Task Force within the Pulmonary Vascular Research Institute with the overarching aim of advancing women's health. One of the diseases with marked sexual dimorphism is pulmonary hypertension. It is characterized by abnormal proliferation and inflammation in pulmonary endothelial cells and smooth muscle cells. This leads to narrowing of pulmonary arterioles, and if left untreated, it leads to right heart remodeling, right heart failure, and death. There are 5 groups of pulmonary hypertension. I will mainly focus on group 1, pulmonary arterial hypertension, and group 3, pulmonary hypertension due to lung diseases and hypoxia. Sex differences exist across all groups of pulmonary hypertension. Females survive better with PH than males, and this is mainly possibly because of the better adaptation of right ventricle in females compared to males. Group 1 is 4 times more prevalent in females than in males, and no one still knows why. And in group 3, females have higher pulmonary vascular resistance than males. And biologically, these sex differences arise either due to sex hormones or sex chromosomes. In terms of sex hormones, the most studied sex hormone is estradiol. However, its role is complex. It has been shown to induce proliferation of pulmonary artery smooth muscle cells. However, it's protective for the right ventricle functioning. So these opposite functions led to a term estrogen paradox in PH. Another mechanism is sex chromosomes. Males have X and Y chromosomes, females have 2 X chromosomes. Most of the genes on the second X chromosome are inactivated. However, up to 30% of these genes escape this inactivation, which leads to double dosage of these genes in females compared to males. Among these genes, there are genes that have been shown to be implicated in pulmonary hypertension before and autoimmunity. For example, TLR7, MAO-A, NOX2, TIMP1. However, they have not been studied in the context of sex differences in pulmonary hypertension before. So now I'll show some published data where the first aim was to look at sex hormone independent responses of human pulmonary microvascular endothelial cells to hypoxia in the conditions of physiological shear stress. So I used primary human pulmonary microvascular endothelial cells and applied a modified orbital shaker approach to subject them to physiological shear stress. Shear stress is what endothelial cells experience from the blood flow in the body. I've confirmed that endothelial cells experienced laminar shear stress across the whole well and analyzed these cells with mass spectrometry-based proteomics. I've identified that there was a subset of proteins whose hypoxic response was altered by the presence of physiological shear stress. So here I'm showing one example. It was thrombospondin 1. That's a shame that I don't have a pointer here. No. So thrombospondin 1, it did not change in response to hypoxia in standard static culture conditions. In response to physiological shear stress in normoxia, it was decreased. And in response to hypoxia, only in physiological shear stress conditions, it was increased. So the take-home message from this study was that physiological conditions may reveal biological differences that remain undetected under standard static culture conditions. After that, we validated this data using single-cell RNA sequencing from patients with chronic obstructive pulmonary disease, which is characterized by hypoxia in alveolus and endothelial cells. And after disaggregating this data by sex, we identified that most of the signal came from females rather than males. So the take-home message from here is that disaggregating data by sex may reveal sex-specific responses. To look further into the mechanisms of sex differences, I've looked at transcriptomics and proteomics differences in human pulmonary microvascular endothelial cells and found that male endothelial cells had higher proliferative pathways, while female endothelial cells had higher inflammatory and endothelial to mesenchymal transition pathways. This is the opposite from what Martina has just shown with adipose endothelial cells, which is probably not surprising because this is very different vascular beds and it could be very different between lungs and adipose tissues. And currently at the moment, I'm looking at the role of genes that escape X chromosome inactivation in sex differences in pulmonary arterial hypertension. PH is 4 times more common in females. However, females have better survival than males. I looked at endothelial colony forming cells derived from patients with PH. I cultured them in the absence of sex hormones using charcoal stripped serum for 72 hours, stimulated with TNF-alpha, and looked at the cytokine array, 105 cytokines. And this is a part of the project of our master student, Tommy Wenkmei. And there were a few different clusters. One cluster, the left cluster, is cytokines that were not sex different. They were increased in response to TNF-alpha in both male and female cells. However, the right cluster is the cluster in which cytokines were decreased in males in response to TNF-alpha, but increased in females in response to TNF-alpha. So we're currently validating these findings. The next step would be to incorporate these cells from patients into a physiological environment, for example, using organ-on-a-chip approach. And this is a project of Mei Yamamoto, a PhD student between Beata and myself. She incorporates human pulmonary microvascular endothelial cells from males and females into organ-on-a-chip, which are co-cultured with pericytes. Pericytes is a novel emerging cell type, which is important in microvascular remodeling. In this approach, we can separately isolate the cells from each other and look at the transcriptomics and proteomics analysis. So we subject these organ-on-chips to different pathological stimuli like hypoxia, TNF-alpha, and combination. And some preliminary data show that after running mass spec-based proteomics, we see two clusters of cells, pericytes and endothelial cells, nicely confirming that they are two different cell types. In terms of sex differences, we see some sex differences in oxidative phosphorylation pathway and interferon gamma and alpha signaling pathways. So to conclude, it is important to incorporate physiologically relevant environment into in vitro work, because this might reveal real biological differences that can be missed in standard static culture conditions. There are sex differences in human pulmonary microvascular endothelial cells and in CFC cells from PH patients, which are mainly related to inflammatory pathways, and they might explain sex differences in pulmonary hypertension. Organ-on-a-chip approach is a powerful tool to study sex differences. It allows investigating drug responses, different cell types, and also can be applied to vascular beds from different organs. Thank you very much for listening. Thank you to students, colleagues, collaborators, and funders.
Thank you very much, Daria. Questions from here? Please raise your hands if any questions. I'll ask you one, because I thought this was really interesting. So Hester also mentioned that of the work that she did, although inflammation was higher in the males, interferon seemed to be the highest in the females, which is interesting, given the interferonopathies and what we know about interferon and autoimmune disease in females. And you noticed that as well. So do you think that maybe interferon could be an inflammatory mechanism that is uniquely elevated in females, let's say, and can go hand in hand maybe with remodeling?
It could be. I think we still don't know much about sex differences and inflammation. And at some conferences, you would see one talk saying inflammation is higher in females. Next talk would be saying inflammation is higher in males. So there's a lot to disentangle there, for sure. Yeah.
Thank you. Any other questions from the floor? Okay, so I think we will conclude this session. Thank you very much, Daria, and to all of our speakers. Another round of applause, please. And to close us off today, Professor Anna Randi, who will just give us a final few words.
Well, I'm here just with the very easy and pleasant task to thank everybody for this brilliant afternoon. Thank all the speakers for their very stimulating talks. Thank all of you for coming. I hope that you will come away from this afternoon inspired with some new, perhaps, ideas about possible how to take forward your research or how to start new collaborations in order to focus on women's health, which finally has come to the forefront, which has been a long time coming. And I will pick up on Manuel's previous comments. I don't think he thought he would get away with it, that we're going to study women's health and disease to help women. And then hopefully that would also help men. So I'm left with thanking, first of all, Daria, who basically did all of the hard work, leaving Ramsey and myself with very little to do, with the help of Lucy, who was incredibly efficient at all this. Thanking our sponsors, particularly the Tabor King Research Fund through Ramsey's research funding, the BHF Center of Excellence, of course. And this is a meeting of the Vascular Science Network, which was set up many years ago by Professor Dorian Haskard to bring together everyone, as many people as possible within Imperial College who are interested in blood vessels, and I would say now blood and lymphatic vessels. So this is a cross-college, cross-disciplinary network. And as a reminder, blood vessels are everywhere. So this is not just about the heart, it's about anything that involves blood vessels. Therefore, if you're interested or curious, go check out the website. And if you have any ideas of what you would like the next meeting to be about, please reach out and contact us. Thank you, everybody. Drinks awaiting.
Space is going to be available until about 8 o'clock. But if there's anyone external, please let us know, because you may not be able to get out after 7. Thank you. You'll be locked in here forever.